session, and as everyone will know, this is really just callback session for the Ministry of Sport and Youth Affairs. And it's specifically just to inquire and get some clarification subsequent to the public hearing held on April 13, 2016, and the site visit conducted on May 23, 2016. This meeting is being held in public, and it will be broadcast on Parliament's Channel 11, Radio 105.5 FM, and the Parliament's YouTube channel, ParlView. I would now call upon the officials from the Ministry of Sport and Youth Affairs to introduce themselves.
Good afternoon, Chair and members of the committee. I am Joan Mendez, Permanent Secretary, Ministry of Sport and Youth Affairs.
Good afternoon, everyone. My name is Adrian Raymond. I'm the Acting Chief Executive Officer of the Sports Company of Trinidad and Tobago.
Good afternoon, everyone. My name is Ian Rabin, Deputy Permanent Secretary, Ministry of Sport and Youth Affairs.
Good afternoon, everyone. My name is Wilfred Fullerton, and I'm the Project Consultant for the Nationals of Trinidad and Tobago.
Okay, and in the interest...
Good afternoon, everyone. Tennille Clark, Sport Company, Project Administrator.
Sorry, Ms. Clark. Thank you. Just in the interest of time, I'll just ask the members, because we are familiar with the officials from the Ministry of Sport and Youth Affairs, but for the purposes of the broadcast, if members could just quickly identify themselves.
Melissa Ramke-Soon, member.
Nicole Olivier, member.
Daniel Duki, member.
Alison Bash, member.
Wade Mark, member.
Ayana Webster Roy, member.
After.
And I am Bridget Anizet George, Chairman, and we are ably assisted by our Secretariat, Ms. Jacob, who's the Secretary, and Ms. Samuel, the Assistant Secretary. And I would invite, firstly, Member Mark to raise the supplemental concerns of the committee.
Thank you, Madam Chair. Welcome, Madam Permanent Secretary and your team. Just wanted to get clarification on this additional 20 acres of land that we would like to acquire for purposes of increasing parking facilities, the construction of a sportel, and the other facilities like jogging, drag racing. We know it's an idea and it has been discussed informally. But what we were concerned about is, are there any concrete measures or steps being taken to have this particular set of ideas translated into concrete reality? And if there's such an approach, could you tell this committee what period of time you envisage this reality to come, this dream rather, of acquiring these 20 acres of land to become a reality, so that for all kinds of purposes, we would be able not to only have more parking facilities, but the access both in and out of that venue would be easily facilitated. So essentially, that is the clarification that we are seeking to have as we go forward.
Good afternoon, member, chair, through chair. At this time, as you had rightly said, it's just ideas that we have been brainstorming. At the moment, we are looking at the proposals, but we have not finalized, because we will have to gain the acceptance of the board as well as the line minister, and certainly a submission will have to go to cabinet, following which we will certainly set out a project plan. The critical issue will be the financing. And because of the economic times, we may not be able to fully explore from the government perspective of financing. We may have to look at public-private partnerships. But as I said, it's just ideas that we have been exploring, but nothing has been made very concrete in terms of going forward. I will ask Mr. Riemann if you wish to provide any additional information.
Member Mark, one of the things that we've been looking at as well is that we have a minister, we also have a PS and a DPS that believe in data-driven information. So part of what we've also been looking at as well in terms of the development of the business model, and Chairman, I do recall your deadline and we're working towards that, the finalization of the document. But one of the things that we recognize is that if it is that we're to attract international athletes, particularly for extended training periods of time, etc., there is a need for a particular sort of dorm facility available at the venue. So a lot of that right now is working on getting that particular information, that particular data, doing the level of consultation that is necessary to make sure that we get value for money in terms of the investment. In addition, we also have been having discussions with the national governing bodies of sport that will be utilizing the particular facility in terms of what is the level of participation, for example, in BMX biking, and therefore how do they necessarily intend to build the capacity that exists right now and to formally bring that branch of cycling under their wing so that there could be a certain level of oversight, or we could look at funding and additional support services that we need to provide for those athletes that we participate. So based on those things, that's kind of where we're at right now. There is a general buy-in conceptually from the PS, the minister, and to an extent the board. But as the PS would have mentioned, we would have to really formalize it, cost it out, and make the necessary submissions and get the approvals, source the financing, and then we'll move forward.
And thank you, Mr. Riemann and PS, and then might I invite Member Coffey to ask the questions relative to the Brazil Recreation Ground and the Las Lumas Recreation Ground.
Thank you, Madam Chair. I had some further questions from the submissions that I saw. Now, it referred to the contractor hired placing the sign at the wrong location. Now, I see here that Trifecta was hired as a contractor. Is the contractor that is referred to in your submission as placing the sign at the wrong location Trifecta?
No, it's not Trifecta. It was a separate contractor who was simply responsible for the installation of the signs. The name of the contractor is Southern General.
Okay. When the sign was placed, now it says here that 1.6 million or thereabouts was spent, but I'm trying to establish a timeline. When was the work done on the Brazil Recreation Ground?
The works would have been done from a period of 2012 to 2013, and then there would have been a defects liability period of 1 year at the completion or the handover stage, which would have taken the project life cycle to 2014. But the works would have been completed in 2013.
Have you all been doing site visit to establish what transpired?
In terms of the works being done?
Yeah.
Well, what would normally occur is that there'd be a site engineer that would be assigned and a project manager assigned to the particular location. We would have the consultants also would provide a certain level of oversight to make sure that the works would have been completed and done. In addition, we'd have also have our own internal quantity surveyors making sure that the value of the work was completed, etc. There'd also have been a final inspection that would have taken place before the handover of the facility, where they'd have looked at whatever particular snag lists, etc., need to be done. And once that is completed, then the project would have been considered to have been reached its final stage, which would have been, we would have handed it back over, in this case, to the regional corporation. Yeah? Yeah, the regional corporation.
Well, you say here that the work is 100% complete. This is in my constituency. I pass it regularly.
Right. These were phase 1 works, by the way, yeah? So it would have been specific to, it would have been specific to the, it is specific to what is listed out as the scope of works under Brazil Recreation Ground. Phase 2 never occurred.
So then the project is incomplete.
Well, the project under phase 1, what we would have contracted, made the contractor do, or what we would have contracted the contractor to do, would have been completed, yes.
What's phase 2? What's phase 2?
We actually didn't get to phase 2. What was approved was the phase 1 of works. The company actually didn't get to phase 2. We didn't scope it out. We didn't tender it out. Yeah.
I'm trying to understand, because what you have now is a incomplete building that is a danger to the public. I did not understand the fact that it was given out in phases, and when I look at the summary sheet of the completed works, for example, it says that additional filling and upgrade works due to unanticipated existing poor soil condition. So unanticipated existing poor soil conditions. There's an oxymoron somewhere in there, because it's existing and you're doing work.
Right.
So how could it have been unanticipated?
Well, the thing is that what would have occurred is that within any particular project, once you go in and you discover particular issues, etc., and that kind of thing, you don't necessarily abandon the project. You will try to find a solution, and part of the solution would have been additional filling, and they would have done the necessary works to ensure that the project could be completed.
In other words, you had an estimate, but the contractors did not do a soil test before they started the work. Okay. I also wanted to understand why the relationship between the employee who led the exercise and the fact that he left the company when his contract came to an end and was not renewed. Now, what is the relation of that information to the fact that the sign was placed in the wrong place by the contractor?
There was a question that was asked in terms of if any disciplinary action or what additional action was taken against the particular employee who would have had the oversight on the installation of the particular signs. That particular employee is no longer with the organization. Their contract would have come to its natural end and it was not renewed.
What I'm trying to get was that the non-renewal of his contract, did it bear any relation to the fact of the poor supervision, if I may use that expression, for this exercise?
There were a number of issues that were factored into that particular decision. A number of issues, not necessarily specifically related to this one, but there were a number of issues, and they would have been based on a particular performance evaluation that would have been done by his immediate supervisor and a particular recommendation made. But there were a number of issues, not specifically related to this particular issue.
All right. I just have two more questions. Was any money expended on the last Numerous Recreation Ground?
No.
All right. So the $1.6 million was spent totally on the Brazil Recreation Ground.
That's correct.
And the sign that was erected in Las Tumas was, no money was paid for that.
It was an error. It was part of an overall package of a number of signs that would have been installed. And my understanding is that the contractor, and I did investigate, my understanding is that the contractor was in fact paid for the installation of all those signs. It wasn't just one, it wasn't just two, it was a series of signs across the country. And the contractor was paid overall for the package.
Okay. I know several signs, similar signs that are on places where no work have taken place.
I understand.
All right, so, but we'll get back to that another time. Thank you.
Thank you, Member.
We have one last question, and I call upon Member Ramki soon.
Thank you, Madam Chair. This committee had conducted a site visit to the Velgrum Cycling Center, where we learned of the UCI Category 1 certification. And we also learned that this is a one-of-a-kind facility in Trinidad and Tobago, or in the Caribbean. And we would like to know if this facility has been ranked or is being ranked, and what's our ranking?
My understanding of it is that there's no particular ranking per se of facilities in terms of this is the best facility or this is it's all very subjective. There are a number of factors that go into a determination as to whether a facility is considered ideal for a particular event or whether it's considered ideal for training, etc. The only ranking we do have is specific to the track and the quality of the track. The quality of the track has the highest rating possible, determined by UCI, United Cyclists International, who is responsible for, who is the international body responsible for cycling across the globe. They have given it the highest possible ranking, but there will be several other factors that go into determination as to whether this is a preferred venue or not. There are issues related to whether you prefer the venue for training, whether you prefer the venue for events, etc., and that kind of thing. And those are some of the factors that we have to work out: proximity to hotel and dormitory space, proximity to restaurants, etc., and that kind of thing. You'd look at also areas that cyclists can go do their road works, etc., and that kind of thing. The climate, the level of social activity, etc., will all kind of factor into that as well.
Thank you so much, Mr. Raymond. I just want to ask Mr. Fullerton a question, and it's just to clarify. My recollection is in the tour of the facility, which I think you really spearheaded. There was a mention of 114. What we don't know if it's 114 such facilities in the world. It is ranked 114th, and is that we're trying to get some clarification. I don't know if we've got it wrong. If you recollect what we're referring to.
Okay, thank you for Madam Chair. It is not a ranking of 114. It's a 114th track that is Category 1 status that has been constructed.
In chronological order,
yes, ma'am.
It is the 114th
Category
to come
1,
into being.
that is
okay.
correct.
Thank you very much. Okay, and I think that's all we have invited you all back for. I want to thank you all for coming and lending the assistance that you've lent. And we wish you all a pleasant evening. You all are excused. This meeting is now suspended to allow the officials from the Ministry of Sport and Youth Affairs to leave and the Ministry of Health to come in. This public hearing of the Public Administration and Appropriation Committee is now resumed, and I would like to welcome the officials of the Ministry of Health. The Committee on the Public Administration and Appropriations has a mandate to consider and report to the House on A, the budgetary expenditure of government agencies to ensure the expenditure is embarked upon in accordance with parliamentary approval. B, the budgetary expenditure of government agencies as it occurs and keeps Parliament informed of how the budget allocation is being implemented. And C, the administration of government agencies to determine hindrances to their efficiency and to make recommendations to the government for improvement of public administration. The purpose of this 5th public meeting for the 11th Parliament of the Public Administration and Appropriations Committee is to examine the 2016 expenditure of the Ministry of Health under the following subheads: current transfers and subsidies, development program consolidated fund, and infrastructure development fund. The committee is desirous of hearing from the Permanent Secretary and other key officials of the Ministry of Health to discover the challenges being faced and determine possible solutions to these challenges. The role of the committee is to assist the ministry to achieve efficient delivery of services while ensuring that expenditure is embarked upon in accordance with parliamentary approval. I therefore now invite the Permanent Secretary of the Ministry to introduce herself and her team.
Good afternoon, Chair and members. Thank you. I am Donna Ferraz, Permanent Secretary, Ministry of Health, and I will ask my colleagues to introduce themselves from the left and then from the right in the back. Thank you.
Ignat Misir, Chief Medical Officer.
Hi, good afternoon, Chair members. Lawrence Jai Singh, Director of Health Policy, Research and Planning.
Good afternoon, Ronald Coilers, Project Manager.
Good afternoon, Chairman and members. Stuart Smith, Senior Health Systems Advisor.
Good afternoon, members. Bisham Sitaram, Program Administrator, External Patient Program.
Good afternoon, Mala Kaulesa Tegali, State Council 2, Ministry of Health.
Good afternoon, Veronica Pedro, Accounting Executive 2.
Thank you very much. And can I ask the members of the committee to introduce themselves, starting from extreme right?
Good afternoon, Melissa Ramkisoon, member.
Good afternoon, Nicole Olivier, member.
Good afternoon, Daniel Duki, member.
Good afternoon, Alison Bash, member.
Good afternoon, Wade Mark, member.
Good afternoon, Ayana Webster Roy, member.
Afternoon, Maxi Coffee, member.
And I am Bridget Anizet George, Chairman, and we are ably assisted by our Secretary, Ms. Jacob, and the Assistant Secretary, Ms. Samuel. I would therefore invite the Permanent Secretary to make some brief opening statements concerning the heads under consideration. Thank you.
Thank you, Madam Chair. And good afternoon again to everyone in the room. Thank you for this invitation to discuss the expenditure of the Ministry of Health for fiscal 2016 under the subheads 04 Current Transfers and Subsidies, 09 Development Program as financed under the Consolidated Fund and the Infrastructure Development Fund. I wish to begin by reaffirming the Ministry of Health's commitment to the equitable delivery of quality health care to the citizens of our country. We do so through a mix of models: direct delivery, outsourcing, through the regional health authority system, which delivers clinical care, and through partnerships with a range of non-government organizations, as well as regional and international health sector bodies. It is through subhead 04, Current Transfers and Subsidies, that we fund the RHAs, NGOs, and regional and international partners, and currently 27 non-governmental organizations. Our allocation for fiscal 2016 is $4,708,984,248. Releases as at June 10th, 2016 are $398,167, while actual expenditure is $2,257,915,435. The Ministry of Health also manages a robust development program with an allocation of $126,800,000. Releases under this vote amounted to $61,248,702 as at the end of May 2016. And expenditure to date is $40,918,715. Under the Infrastructure Development Program, we fund major infrastructure works. The amount allocated is $616 million for fiscal 2016. Of this amount, releases as at the end of May were $186,982,814, while expenditure to date is $186,545,545,029. These funds are mainly used for the construction of new health facilities. Madam Chair, this is our financial position, and I know that, as you said, you wanted to get into details of how we're doing the expenditure, and therefore we are open for the conversation.
Thank you, Madam PS. I just want to ask a few general questions before I open the floor. And my first question, to sort of put us in a context, in one of your responses, there was reference to the core functional areas of the Ministry of Health. And I would, like, if maybe you could let us know what you all consider to be the core functional areas, what is really meant by that term.
Well, as I suppose the name gives it, it is the delivery of healthcare services in an equitable manner. We would know that in around 1974, the ministry undertook a health sector reform program, and it was agreed that the clinical services would be delivered by the RHAs, and that we have 4 in Trinidad and 1 in Tobago. Apart from that, there are still some 25 or so services known as vertical services, and these would include things like the chemistry, food and drugs division, the school health system, health promotion, insect vector, and the like. We, of course, well, these would form, because generally speaking, the ministry is responsible for public health across the nation. Part of our remit would be regulatory as well, as in the case of like the chemistry, food and drugs division. The core services, I would say, go back right to and the ones we know best, go back to the care services in the RHAs. But I'm not sure like what else you would want to be apprised of. Sorry.
It's just really the terminology in terms of your statement was internal policies and procedures are reviewed and revised accordingly to reflect current practice across the core functional areas of the ministry.
Okay, yes.
And it was really a sort of definition of what is comprised in that.
I would still go back to delivery of healthcare, but there are many strands to this. So as a for instance, apart from what we all know about the hospitals and the care there's also the issue of primary health care, which would be related to our health education system. As well, if we look at the insect vector control, that is key for us because that also gives a certain trend, or not trend, sorry, but it also, in terms of public health and the status of the country, the range of communicable diseases. Perhaps I could ask Dr. Messire?
Thank you, PS. If we want to add to that list, Ministry of Health, one of our core functional area is policy setting, and we also have a very important regulatory function, as PS was discussing. Chemistry, food and drugs, for example, deals with regulation of medicines, cosmetic and medical devices and so on. So we have a very important regulatory role. So that is one of our core functional areas. In addition to that, areas like health promotion, prevention, primary prevention of a number of diseases and conditions, so that these would be the core functional areas.
Thank you very much. And the other general question I wanted to ask, again, in terms of setting the table, is does the Ministry of Health have a strategic plan?
We are just about at the end of the strategic plan. plan 2012 to 2016. So currently we are looking at rounding that out and planning for the development of a new plan.
And maybe PS, you could share with us in writing a sort of analysis of achievements with respect to what you've done as against the plan, any difficulties in having achieved any of the goals or objectives of that plan. And maybe you can send that to us by Monday Monday's a holiday. So therefore Monday's a holiday, so I would say Tuesday the 21st.
Yes, ma'am.
And lastly, I just wanted to ask, in terms of, has your ministry been affected by the 7% cut in expenditure? Firstly, whether that 7% cut has been applied across each of the three subheads under consideration, and if yes, how has that, if at all, reduction affected the programs and projects funded under these subheads?
I will hand over to Ms. Pedro, but I can say that we chose to go only the route of recurrent expenditure. We really did not want to touch the development program. Ms. Pedro can tell us the votes under which we looked at, but we did feel that we would have a greater amount of flexibility by utilizing, effecting the 7% only in the recurrent.
Okay, so therefore, PS, if it didn't occur under transfers, current transfers and subsidies, DP, Consolidated Fund, and IDF, I think I really will be satisfied with that. And therefore it will lead me to one other general question, and this comes out of the Auditor General's report 2015 at page 60, when they were talking about internal audit, and the point was that evidence of internal audit checks was not seen. Sorry? This is page 60.
Right.
Subparagraph 2.151. And basically, it says evidence of internal audit checks was not seen on the accounting records examined. Further, from the 20 areas identified in the internal audit work program, 13 areas were not audited by the internal audit unit, if I've read it properly. Okay, and I just wanted to know, I mean, that was for 2015, but how do you, as the Permanent Secretary, in the light of such a statement, assess the performance of your internal audit function as it relates to capital expenditure?
Thank you, Madam Chair. Yes, and that comment was viewed very seriously by the ministry. I am aware, because when I spoke to our internal auditor 3, that last year what would have happened is that the already inadequate staffing of the unit would have had to deal with the payment of arrears for public officers last year, and that I know created a very big demand. We are still grappling with an inadequate number of persons. Also, the level of staff that we have, I think for the breadth of the ministry and the kinds of transactions that we do have, that is somewhat worrisome. I am in contact with the Service Commissions Department with a view to trying to bolster the resources there. But I can assure that I am keeping a closer check in terms of the work program. The work programs are brought up quarterly, and we keep a review on it. The auditor and I also discuss any problems that she's having, As a for instance, they're very busy right now rounding out the audit of the arrears for the payment for the health sector workers, and we did have to pull on a couple other people to be able to do that and adjust the work. She has assured me that nothing will suffer really, they are able to make up. So we're keeping a closer watch. We do know that resources are not at the level that we would like. Also, she and I have been talking about training to ensure that as far as possible with either what we can do or what is being offered by the Treasury Division, that we try to keep our staff on track. That having been said though, I would like to record the very strong commitment of the unit, even in the face of their inadequate resources.
Okay, so that moving forward, because your span on development program is very wide, extensive, so that the commitment is going forward, some greater check is going to be placed on the DP. Okay, and therefore, thank you very much, and I therefore open the floor, and I invite Member Udu.
Thank you very much, Chair, and may I add my own welcome to you, PS, and your staff, many of whom are very familiar to me, and to say that I've had the pleasure of working with them in the recent past, and I thank you for being here today. Just to follow in the vein of the RHAs being a very important part of the service delivery mechanism of the Ministry of Health, and I note from your submission that a total of approximately 1.3 billion was spent by the 4 RHAs in the 6-month period up to the 7th of March, which is the basis of your submission, and I stand to be corrected in these figures, of course. I also note that there was a budgetary allocation of close to about 3.2 billion for the 4 RHAs, which roughly translates into about 1.6 billion for the first 6 months. So in my mind, this represents a shortfall of about 300 million for the RHAs over this period. Bearing in mind that the RHAs are the main service providers for the Ministry of Health, can you then, Madam PS, give the reasons for the shortfall? I'm sure you've covered some of that already, but perhaps more importantly, to indicate how this shortfall would have impacted on the services offered to patients visiting our nation's health institutions. In particular, effect, for example, on investigations, blood tests, x-rays, number of surgeries, and so on. Can I invite you to comment on that?
Thank you, Vice Chair. It is no secret that the entire public service has been impacted by our current economic circumstances. Again, I would want to say that I would offer commendations for all partners and all persons associated with the health sector. We have started in the ministry meetings among the RHAs that are chaired on the one Saturday of each month by the Minister of Health. And that approach has been to allow to discuss issues that are on the table, to be able to come up with solutions as a whole approach, to be able to share learnings, to be able to look forward down the road and to see what emerging issues there are. That has gone, I think, a long way in terms of even sharing best practices about what can work and what cannot work. That having been said, though, the fact is that in terms of the finances, we have had to see where money can be stretched. We have had to encourage for greater efficiencies. We have had to have conversations with suppliers to thank them for their patience. We have just had to manage with what we have under the circumstances. We continue to work closely with the Ministry of Finance, both in terms of the releases, timely releases, in terms of looking at our funding as a whole to determine where we can do less, do more with less under some other votes to try to see also where we can meet payments. The thing is that when you are talking about the health of a nation, it is understandably difficult to choose what you have to do. And I think that is where the issues of how you operate as a whole will carry you a little further. As it stands, we have been able to manage well enough. There would have been sometimes, as you would have known from media reports, where there would have been situations that we would have had to deal with, but we are trying day by day to manage. If there's anything that, as a committee, you would wish to assist us with, at the end of the day, though, the size of the pie is the size of the pie. Okay.
Sure. Thank you, PS. Yeah. If I may continue in the same vein, PS, with regards to the RHAs, and in terms, and of course this is perhaps even more important now with limited and less resources, but in terms of monitoring the performance and effectiveness of the RHAs, I note that the Ministry of Health has service agreements drawn up with these entities. Can I ask you to indicate then, Madam PS, to what extent these service agreements are complied with by the RHAs, first of all, and secondly, whether the Ministry of Health has a system in place to analyze these quarterly reports to ensure that the RHAs deliver the quantity and quality of services to our patients as desired and as, of course, mandated by your strategic plan. And does the Ministry of Health have systems in place to measure health outcomes? I'm just throwing that out as a second part of that question, if I can invite you to respond.
I would start by saying that by and large, the RHAs do comply with the requirements of the service agreements. I would wish, however, to hand you over to Mr. Jai Singh from the Health Policy Research and Planning Division, because it is their unit, their division, that would do the groundwork on the monitoring. I may come back to add, and I may also ask Mr. Smith and Dr. MSYA if they would have any comments.
Sure,
thank you.
Hi, thanks for the question as well. What we have done in the last year and a half, we have really updated the annual service agreement. In the previous years, it was done at a high level with about 154 indicators, which basically was difficult to monitor and track. So what we did, we condensed the entire ASA to the services of the RHA itself, in terms of the hospital services. And since the new government, we have included the primary healthcare as a major part within the ASAs, including infrastructure, including HR, and most importantly, including indicators that are confined to the services of the RHA itself. So we have broadened the indicators to about 50 core indicators, and also we have included a part of the compliance ratio. So from those spreadsheets that we are actually developing, you could track and monitor each aspect activity of the RHA itself in compliance with health outcomes too as well. Because normally the health outcomes were not realistic, and we have adjusted all the indicators and went through about 2 rounds of consultations with the RHAs as well. So to date, the ESA is fully completed. It's just the signing off of the ESAs and possibly the training and consultation against on the operational side of the ESAs within the RHAs itself. So we're hoping that should be completed by the end of the month.
To answer the question regarding the measurement of health outcomes, I would let the committee know that the Ministry of Health, through our international partners like PAHO, WHO, and so on, there are certain requirements that we must report on. And this is particularly important for us as a country to ensure that we complete these in a timely fashion, so that in our vital statistics, our infant mortality rates, maternal mortality rates, a number of these are done routinely and submitted to the international bodies so that we can do a comparison with other jurisdictions to see how well we are performing or how unwell we are performing. So that the answer to your question is yes, there are a number of parameters that we do use and we do report on every year to the international bodies.
Thank you, Madam PS.
Thank you, Madam PS. And just to add, Honourable Member, with respect to the monitoring of the quality and quantity of care that you have asked about, we have asked the RHAs to focus on the maintenance of the health gains over the years. So even despite the Permanent Secretary's statement about the state of the economy and the limited resources that we have, what we are trying to do, we have asked, is that all of the RSAs place a focus on maintenance of the health gains that we have had, and the way we are doing that is through both personal health services in terms of what we offer in the secondary and our primary healthcare setting, and our population-based health services such as our immunization rates and so forth in terms of vaccinations of our children. We also now monitor in terms of some of the health outcomes. We look at the basic epidemiology, and what we are recognizing, at least now, is that our mortality rates are in fact actually, if not consistent, are in fact better. And we have seen some of that with respect to our own maternal mortality, which is now getting better. So at the end of the day, despite the reduced resources, we can in fact say we are actually doing better in some areas and maintaining the health gains that we have had from the past.
Thank you. If I may, just one more question with regards to the RHAs, PS, and perhaps just an opinion here. But do you believe that the RHA system, as presently constituted, is the best mechanism for ensuring that the public funds expended in healthcare represent value for money with regards to efficiency, safety, and effectiveness?
It sounds like a policy question. What I can say is that it is the system that we have now, and therefore we make the best use of it. We, we continue through the monitoring mechanisms that we have to collect data to determine how we can improve what we have. As well, you would be aware that there is currently a committee in place that is looking at the RHA system, or at least some key aspects of the RHA system. And once that report comes in as well, I believe that if necessary or as necessary, the way forward would be determined. I trust that I've answered your question.
It's a very safe answer.
Hi, good afternoon, Madam Chair. Through you, I wanted to find out about our waiting times for patients and how we rank regionally to access like surgeries and different things at the regional health authorities.
Now, before I answer that question, I have to let you know that waiting times can be very subjective in terms of how we interpret it. What I can tell you is that when a patient gets a referral for any service in a secondary institution or a hospital, that referral is assessed by the particular discipline. So whether it is obstetrics, whether it is orthopedics, whether it is surgery, an assessment is done, and based on that assessment, you are given an appointment. So, for example, if you have something that, let's say, is urgent or an emergency, obviously you will get a faster appointment, or you get faster attention. So that when you look at it for the average now, when you say the average waiting time to get an appointment to see an orthopedic doctor, for example, that will be dependent on the number of referrals that you have and the requisite care that that person would need. You know, so that somebody who has, let's say, what we call septic arthritis, meaning that you have infection in a big joint, that is an emergency, so you get an early appointment compared to somebody who is, you know, needs a hip replacement for that is not as emergent a problem as somebody, so that when we look at the waiting times, you have to factor this in. Now, compared to other jurisdictions, our waiting times are comparable to any island in the Caribbean, and even as far as North America and Canada. Of course, because of our public funded system, you know that we can't do the decisions and can't take decisions as you would probably have in North America, where it is a system that is driven by health insurance. So that when you do the comparison, you have to take all of these things into account before you can pronounce on whether, you know, how well we are doing or how badly we are doing. I hope that answers your question.
Somewhat. Also, if you compare the different RHAs, if someone has a particular case, would the waiting time be similar? Is there a standard no less than 3 weeks before you see a doctor for this particular issue?
And the answer to your question is in the different RHAs, obviously the waiting times will be different. And it's because of the complexity of services that the different RHAs will provide. And let me give you an example. If a woman is diagnosed with breast cancer, in every hospital in the country, you must have your surgery within 1 month of diagnosis. That is the benchmark we have set for women who would have been diagnosed with breast cancer. 1 month, you are supposed to have your surgery. Once surgery is indicated, you're supposed to get your surgery within 1 month of diagnosis. Once what we call the multidisciplinary team, that is the oncologists, the surgeons, the other people who are involved in the care, nursing and so on, if they determine that surgery is part of the modality of care, then you will have your surgery within 1 month. If it is a tumor or cancer that probably you need to get radiation first, that too is done within 1 month. So that it depends on the case, so that when to talk about waiting times and so on, we have to be very particular. Sorry.
In that scenario with breast cancer in 1 month, are all the RHAs following through with that 1 month time frame? That's what.
And the answer to that is yes, because the ministry has said that in terms of our service level agreement that you must do that. Now, all the RHAs would not do that type of surgery. So you have to know that sometimes you have to refer to other RHAs to get your surgeries. And I mean, I would share another example with you. In patients from Tobago, for example, where you may have a pap smear that is positive and suggestive of, let me say, cervical cancer, these patients are referred to a hospital where you have what we call colposcopy, where the doctor can do a more detailed examination and probably do a treatment that could cure you at the same time. That, again, depending on the logistics, if you have to leave from Tobago, for example, and come to San Fernando General Hospital, obviously we will not meet that time frame, because the logistics, for travel and transport and that sort of thing. So so it will vary. The point I'm trying to make is that we have to be careful how we interpret that. And yes, between different RHAs, the waiting times may be a little bit different, but we try to benchmark what is the minimum standard of care that we will provide. Okay?
Member Coffey.
Thank you, Madam
Chair. Sorry, I think Mr. Smith. If I may, Mr. Smith wanted to add as well.
Sorry. My apologies. That the other piece to the answer is that where we, in our RHA systems, where we have specialist services offered at particular hospitals. And so I'd want to suggest, for example, as one example, cardiology services. Our main referral hospital in the public health system for interventional cardiology is the Eric Williams Medical Sciences Complex. So what you will have is a centrifugal flow of all the patients being referred, once they're not treated in the private healthcare system, coming to the Eric Williams Medical Sciences Complex cardiology clinic for any interventional procedure, where it's an angiogram, an angioplasty, or so forth, because that is where our cath lab is at this point in time, other than the one in Tobago. So the triaging, as the CMO has suggested, will be therefore based on the clinical assessment of the patient in terms of that time from the need points of view. So because it's the entire public population that is now accessing care at this single facility.
you very much. Member Coffey.
Thank you, Madam Chair. I wanted to look at your responses on page 6, question 9, on the ministry's role in preventing, detecting, and investigating fraud. Now, the response of the ministry is that it has a policy on fraud detection and conducts periodic assessment and evaluating of entities to ensure that all controls are maintained. I wanted to put that in the context of what occurred with the Children's Life Fund, and when was the fraud detected, and what learnings has the ministry had in terms of treating with fraud from that experience?
Thank you, Member. I will ask our legal counsel to answer specifically as it relates to the situation at the Children's Life Fund, and then afterwards I'll talk generally about the rest of the question.
Thank you, PS. Thank you for the question. What I will say is that there were allegations of fraud with respect to the Children's Life Fund. When the allegations of fraud came to the forefront, the Board of Management of the Children's Life Fund, they took steps to commission a forensic audit into the allegations of fraud. A private firm was retained. The firm they did commence the audit process. They have since completed their process. The final report was submitted to the new board of the Children's Life Fund, so that would have been end of April, May 2016. The board is actually meeting as we speak, and one of the matters for discussion is to thoroughly review the recommendations by the independent auditor and determine what measures and steps need to be taken moving forward. Apart from that, there is also an ongoing police investigation into the matter, so I can't say much, but that is continuing. Thank you.
Thank you, Ms. Carlessa. And member, we, again, coming out of that report, once the board approves it, we will also be looking at it, keeping a closer eye, but also we recognize that from our policy, we've also talked about issues of training. We will seek to ensure that the systems are tightened as well, and that where we can, in terms of the legal framework of that board, be able to have a greater and more close insight and oversight of the fund for the administrative processes.
Okay, thank you. What concerns me with this particular issue was that the reports came from the media, from people who, members of the public, and it seems that the ministry did not have the processes to detect the fraud and I got the impression this was going on for a while, to detect the fraud early and to make the necessary interventions. Would that be correct?
I think, member, I would not be able to respond to that properly. I cannot say that I know the in-depth history of the case, and that is why I said we will have to wait, see the outcome, and determine how much more closely and what systems we have to make sure are improved.
Thank you. I just wanted to go on to...
Member Coffey, if you would permit me, if you're moving off this question 9, if you just permit me just to ask certain questions on it,
okay,
please. And P.S., you know, as again, same policy on fraud, there's a sort of general statement that the ministry has a policy on fraud detection, but there is no detail with respect to what is this policy, you know, what does it entail, whether the policy has aspects for conflict of interest, for whistleblower. There's no detail at all, and you know, I'd like you to share with us some depth about the policy, one, And secondly, in terms of the more specific discussion with Member Coffey, while there are lessons that you said that you all would have learned from the Children Life Fund debacle, and learnings for that, what I want to know is if the learnings would be generally applied across the board to all your programs and treating with all the other entities on the approval.
Thank you, Madam Chair. One of the things that I can do is submit when we're sending in the other information on Tuesday. I can submit to the committee a copy of our policy. I don't know if you would wish for me to just read the contents as to give a sense of what is inside of there.
Maybe, Madam Permanent Secretary, if you could just give us maybe some broad captions so we can see what sort of focus.
Okay. We do have the definition stating it as the intentional force, representation, or concealment of a material fact for the purpose of inducing another to act upon it to his or her injury. It is referred to as an intentional act by one or more individuals among management, those charged with governance, employees, or third parties involving the use of deception to obtain an unjust or illegal advantage. It goes on to describe in detail the actions that constitute fraud. There is a model of the fraud management framework. It also carries a statement committing the ministry to ensuring that opportunities are reduced to the lowest possible level, that effective controls are maintained, and that the system and procedures are reviewed to improve following detected cases of fraud, which I guess would tie into the learnings from any such matter. The ministry will also, alongside that, promote and make every effort to maintain a high ethical culture and standards of honesty in all of its operations. We also talk about awareness and training to be able to provide targeted training to all employees to ensure that they are aware of their responsibilities. The ministry has also indicated that we will periodically assess our vulnerability to fraudulent activities and develop and maintain mechanisms to mitigate the assessed risk of exposure. The monitoring and evaluation of our strategies as well, we have spoken about that, and we talked about as well to be able to implement mechanisms to continuously monitor our operations to detect the incidents of fraud. Some of this, of course, would tie in to the strength of our internal control through the audit that we were talking about as well. That we will be prepared to investigate all suspected cases of fraud and take the appropriate actions, and we will initiate an appropriate response based on the magnitude of the act to all proven acts of fraud perpetrated against the organization, and that if any such investigation results in recommendation to discipline an employee, then that recommendation must be approved by the PS and be, I would say, in line with all the prevailing policies and guidelines relative to the employment of any officer.
Just let me ask, does this apply only to the ministry, or is your fraud policy also applicable to the NGOs under your remit?
Madam, they would not be applicable to the NGOs, but it is where our monitoring systems for the NGOs would come into place, mainly through the Directorate of Health Policy, as well as through collaboration for the particular functional area under which any such NGO would fall.
Thank you, Madam Chair. I had two other questions. Now, one is under 009, other transfers, Roman 13, legal settlement. Now, I tried to look through the documents, but I couldn't find the sum for legal settlements. I think it's under RHAs, but there's no, could you give me an idea of 20 million? Okay. And I also sought to find the allocation for the external patient assistance program. Where is that?
That is under the DP vote. I can. The three. Thank you. Right. Okay. Vote D002, treatment of adult cardiac, and the allocation is 7 million. The special program D003, special program renal dialysis, that allocation is 15 million. And then waiting list for surgery D007, that allocation is 11 million. And if I may just turn back a little bit to Member Webster Roy's question, you will be aware that there is a policy that was started several years ago, then that was stopped and then restarted, but it was where there weren't enough resources in place. There was some outsourcing. I did say earlier too in the opening statement that part of our model of care is for outsourcing. So some surgeries are outsourced under here.
I wanted to go back to the outsourcing and the detection of fraud. And correct me if I'm wrong about how the program operates. So you have patients who are at the, whether it's an RHA or the general hospital, who would be referred by the doctor to for external care, right? What mechanism do you have? And I go back to the policy on fraud and internal audit to ensure that the doctors who are legally affiliated with some of these institutions are not transferring work that can legitimately be done by the hospital to the private medical facilities. How does the ministry monitor that, given the great sums involved?
We do have systems in place, and I would like to ask Mr. Sitaram, who is the program administrator for the external patients program, to explain what some of those, some of the procedures are, some of the checks and balances are. And in fact, I think we had to share that we had stopped one medical case.
Thank you, Member. With respect to accessing these services to go externally, patients must submit their applications through the medical social workers at the hospitals. To ensure that patients that are not being shelved out of the public sector into private sector, we check with the medical directors and the consultants at the various hospitals to ensure that these services are not available or cannot be provided within a timely manner. Then we seek to send them privately. So we do check to make sure. We also have the check and balance in place, whereas the same doctors who operate in hospitals, they have to maintain their quota of schedule. If there's some depletion in their quota in the public hospitals, we stop utilizing them privately.
What I'm looking for is some kind of independent check to ensure that, you know, the taxpayer isn't being ripped off here. Now, is there any internal audit procedure or even external audit procedure to ensure that only those people who are critical and need that assistance are accessing the program?
We don't have the only external audit at this time would be the annual check that is done by the Auditor General's Department for the accounts of the previous fiscal year. There are, however, several other checks that I have seen since I got to the ministry. There is, for instance, for the radiation care, the patients who need radiation, there is a separate committee that sits, headed by an oncologist, and that mixed committee, they would review the cases and then they would submit their recommendations to the ministry for the eventual approval of the minister. As well, I know that Mr. Sitaram has indicated to me on question when, again, this was new to me several months ago, that the unit has to call the patients for the patients to say, did you get the service? On what date? How many times? Whatever, when was your check back? These are what we have in place. I will, however, share that we have also determined in the ministry that we do want to look at the program as a whole to determine exactly what you said. Are we getting best value? Are there learnings from this? How do we move forward? As well, the clinical, Mr. Smith, you have something to add in terms of the assessment committee for cancer?
Thank you, Madam PS. Honorable Member, the external beam radiation program, which is to treat for cancer radiation, is in fact a specific one because in the public health system down at the National Radiotherapy Center, the NRC, we provide external beam radiation through cobalt, which has been quite therapeutically effective over the years. It's just that the science has evolved, and we now have linear accelerator technology and IMRT and IGRT and all of these new things that can be more specific in terms of the targeting of the tumor. So therefore, to get a balance between what can be treated using cobalt with good therapeutic efficacy and outcome, and who can benefit from using linear accelerator therapy, we have put in place specific clinical criteria, which is assessed by an oncologist and a clinical team. So, for example, one way, for a female with breast cancer that has had surgery, has had chemotherapy, and is now for adjuvant therapy in terms of external beam radiation, what will determine is which side the cancer is on. So, for example, if the cancer is on the left breast, it will be determined that from a tissue-sparing point of view, because of the proximity of the heart and lung, therefore, it will be more therapeutically effective to use a more targeted approach. So therefore, the committee will say, for that patient, linear accelerator would be better than using a broader-based cobalt that may be injurious to the heart and to the surrounding tissue. So tissue sparing is one criteria, one clinical criteria that we'll use. So it's not just that everybody who comes for external beam radiation, because they're first of all to be a patient of the National Radiotherapy Center, which is our single provision for external beam radiation, and then they're referred after using that clinical criteria.
Thank you. But that's not what I was looking for. What I'm trying to satisfy myself that in terms of the application of the program, that the people who really need it are getting access to it. So is there any means test? So for example, can a well-to-do individual who has a doctor who works in the health system, can he get his patient recorded as a patient of an RHA, and then by that route send the patient to be treated through the external program and well, I wouldn't want to cast aspersions on the doctor, but is that possible? Do you have evidence of that occurring?
Thank you, Member. If I could, when I referred earlier to going through medical social worker, it is a means test that is conducted. The means test requires the patient to bring in all of their financial statements, their family financial statements, make a public declaration, all of which is compiled and then submitted with a recommendation through the medical director of the hospital. So there is a means test done on all patients seeking assistance.
So you can say confidently that that doesn't occur?
Yes.
All right.
We have several checks and balances, both at the RH level and at the ministry level for that.
Okay, thank you very much. I just had one question on the legal settlements. Frequently you read in the newspapers about suit for malpractice at the RHAs or the hospitals. Is the $20 million provision an increase or decrease, and how does that work in terms of getting satisfaction for the people who are injured in the health system?
Thank you for the question. The 20 million in this legal settlement that you're seeing here, this is a sum of money that's allocated to the ministry. It is only utilized with respect to where you have a court matter involving an RHA and there's been a court order for payment, so in which case the ministry will reimburse the RHA the value of the court order. There's also an instance where you might have a certain matter, because of the nature of it, the ministry might have directed that the matter be settled, and in light of that, the ministry will cover that cost that comes out of this. Any other legal matters where there are legal fees or settlement costs involving any RHA, those costs are borne by the respective RHAs out of their budget.
And in terms of these settlement, these decisions, if, for example, an RHA is shown to have a lot of legal issues, or a particular doctor has a lot of legal issues arising from the practice, what systems are there in the ministry or the RHAs to treat with those issues?
I will also ask Dr. MSYA to add to what I would say. But at the present, the ministry has reinstituted its Quality Council. Under the Quality Council, one of the subcommittees is for adverse events and near misses. Dr. MSYA is in charge of that, but as well, I am aware that the medical board would also have a role, but I would ask Dr. MSYA to supplement.
As PS indicated, at the ministry we have what we call the Quality Council. Now the Quality Council would look at what we call morbidity and mortality reviews. Now in each RHA, one of the board subcommittees is what we call the Clinical Governance and Ethics Committee. Now this committee is supposed to look at the RHA functions, look at the morbidity and mortality data. They will look at, indirectly they will be looking at, as what you're alluding to in terms of the different practices by different members of staff. It don't necessarily have to be the physicians, it could be any member of staff. In addition, they also look at what we call mortality data in terms of, patients dying, whether it is from, what chronic disease, or whether it is iatrogenic, meaning that it may be some fault of the medical care system, so that these reviews are done periodically, and arising out of these, then it might flag an area that we need to do some kind of remedial work. So, I don't know if that answers the question, but there are processes in place to look at these things. Without singling out anybody.
Okay, what I'm looking for is just one example of having gone through these processes, the action that was taken.
Well, the actions could be, I mean, it's either, it could be like in terms of training and retraining, or sometimes it may be the technology that needs upgrading, or it sometimes your procedures need to be reviewed, so that it's not one, I mean, there's not one thing that you would do in this kind of situation. You have to look at it holistically in terms of the improvement of the system.
Excuse me, Member Chair, sorry, through you, Ms. Cowles has indicated that she will add.
I just want to say that under the Regional Health Authorities Act, the regions do have the power to discipline their employees. So if there is an instance and there are any allegations with respect to negligence or malpractice, the RHA does have certain powers that they can take. They have a certain process that they have to follow, as well as there's always the option of referring the matter to the various regulatory bodies, for example, the Medical Board, the Nursing Council, who they themselves have their own powers to deal with their members of their profession.
Might I call Member Mark?
Madam Chair, I have a couple areas that I'd like to clarify. The Zika virus, the Children's Life Fund, and the matter of health centers and access to them. Now, as it relates to the Zika virus, we have been advised that there have been 40 confirmed cases thus far. Could you tell us what measures are being taken by the ministry to ensure that this figure does not increase further? Is the ministry working in conjunction with the RHAs to ensure that there is not an increase in cases of Zika or Zika cases? And finally, what kind of resources, financial, are allocated to you to address this particular situation if we have to contain the spread of this particular disease or virus?
I think Dr. MSYA and I will share the response. You might want to start with the clinical side and the...
The Ministry of Health, we have instituted a program, what we refer to as the integrated management of ADs, because the root cause of the problem is the abundance of Aedes aegypti mosquitoes in our environment. The components of this integrated management program, it's multi-sectoral, in that we have to involve the regional corporations, we have to involve society generally, we have to involve the schools. So there are a number of activities that we are doing to restrict the spread of the Zika virus in this case. But remember, historically, we have had dengue, we have chikungunya, and now we have Zika. And the root cause, as I indicated before, is because of the presence of Aedes aegypti mosquito. Now, to deal with this, the problem is multifaceted and multi-layered. It has a lot to do with our practices in terms of how we manage our environment, how we treat with solid waste and liquid waste, how we deal with the bottles and so on, the used tires. And so it's the approach to controlling Zika is not only spraying around people's homes. It involves much more than that. So that in the ministry and in the RHAs and in the local government bodies and so on, the regional corporations, we have been meeting on an ongoing basis. In fact, today was our meeting with the regional corporations for them to report on the activities they would have done in anticipation of the rainy season, where we know that the mosquito population, the Aedes population, would increase because of the rainfall around the island. So that the response to minimize the spread of Zika, it involves all of these measures.
Would you like to make your contribution now?
For now.
All right. Thank you. We are looking at resourcing these activities from several places as well. We do have our regular funding under the insect vector division. We are also being able to access some funds under an IDB loan that we have running, the pre-loan, the PROPEF, and we are outfitting our IVCD vehicles with GIS. This will enable us when we go out to spray to measure for the vectors and see where they are so we can be more efficient in how we are spraying as well as being able to create baseline data. We are also doing what is called Combi training, and this is for persons to be able to go out into the communities and encourage citizens, because as Dr. Misiri would have said, a lot of it really comes down to the individual practices. And we are also doing a pilot to put down some mosquito traps, a particular kind of mosquito trap, in the area of health centers and some health facilities, because you can't spray really around those facilities. The efforts, I think, by the ministry have been sustained over the past few months, but really in response to your question, where I was getting to the essence of it, is almost a guarantee that we would not have more than 40 cases. It is really a partnership. Each individual, the community, and then the other public sector agencies that have part of a responsibility to ensure that the garbage is disposed of properly, that people do keep their homes, their surroundings in a particular place, where we have public buildings, that they are clean. At the end of the day, the only guarantee is if we all work together and do what is right.
The Children's Life Fund. Could you tell me if what I read is correct in terms of allocation? Is it 600,000? I saw something in your submission that talks to 600,000.
Okay.
Is that the
And I think
allocation for
no.
2016, 15, 16?
The allocation is actually 2 million. That it was an error. I think maybe at the time what might have been put was the expenditure to date, so that the ministry would fund for all the administrative costs and the running of the office.
Now, you could probably generate what I'm going to ask in writing, or if you want to summarize, that's fine, and then submit it in writing. How many children have been able to access this fund for 2016, for the fiscal year 2015-2016 thus far? How many have been able to be successful in accessing the Children's Life Fund? How many have been unsuccessful in accessing the Children's Life Fund? We are hearing stories that children are dying because of some particular provision in the Act that talks about exceptional circumstances. I understand. And the Attorney General's office has been asked to give an interpretation of that particular expression. You can guide me and correct me if I'm wrong on it. But could you really advise us, if that is so, when would you expect that matter to be cleared up? So that, for instance, children that are waiting, or who may be waiting to access the fund, can do so without the fatalities that we are hearing about. That's the second area I'd like you to clarify first.
Okay, thank you. For 2016, I have the number of persons assisted as being 19, and the number, children, 19,
19, okay.
That is the actual number assisted.
Right.
Number of persons declined 2. And I will ask Ms. Cowlesser, I am aware that we were to receive the opinion yesterday. I am not certain whether we did. In any event, I would wish to indicate that if we did receive it yesterday, I would wish to bring it to the attention of the Minister of Health before making any public statement, please.
All right, and Madam Chair, the final area in round 1, I'd like to address. No, not you, I'm speaking to the chair. Yeah, I'd like to ask whether health centers, I listened to Mr. Stewart very carefully, and he spoke about the issue of sustaining gains, health gains, monitoring health quality in TNT. And I just wanted to ask whether health centers, and I understand there are over 100 of them in TNT, whether the practice that had developed in the recent past, where they were open up to 9 p.m. during the week, Monday to Friday, and they were also open on the weekends up to 4 p.m., Saturdays and Sundays, in order to allow poor people to access health care, because health visits you, challenges that is, at any time. It doesn't do it up to 4 o'clock or 2 o'clock. So I wanted to ask whether that practice is still in existence right now as we speak, or whether there has been changes, and if there have been changes, when would the ministry want to revisit the opening of these health centers up to 9 during the week, Monday to Friday, and up to 4 p.m. on a Saturday and Sunday? Could you clarify for me?
I'm sure, member, that you will be very pleased to know that there have been no changes. The practice, that policy is still in place and ongoing as we speak.
Okay, Madam Chair, thanks very much.
Thank you, Madam Chair. My question is in relation to the submissions on the current transfers and subsidies expenditure. But before we go to that, I have a small concern that I was, after listening to the discussions earlier in this meeting, my concern is in relation to the internal audit reports. And it was indicated by the Ministry of Health in their submission that one of their areas of dealing with this is through risk-based audits. And I would like to know, is it a model that we're following to assess these risks? What is being followed to determine that, before I ask my questions?
I would have to say that I can't answer with any particular degree of detail, but I can confer with our Auditor 3 when I get back and present something to you in writing as to actually the process that she would use. Okay.
With respect to that, when was the last risk-based audit conducted? What were the findings? And if as a result of those findings, if recommendations were made, and if those recommendations had been instituted. Okay?
Yeah, Madam Chair, but just to clarify, is that different to the internal audit report that was dated, the last dated one was 17 December? Would that be a different report? The risk-based audit would be a different report? So the submission that's on number 11 and 12 would be 2 different reports? I'm reading from the submission of the Ministry of Health package that was submitted to the PAAC committee on page 6, number 11 and 12. And it also noted that there were a number of recommendations that were implemented and some outstanding. So I don't know if you can tell us also how many of that was.
Not offhand. Okay. Can I submit that in writing in detail? Thank you.
Okay, so let's move to the table that was submitted by the Ministry of Health in relation to current transfers and subsidies expenditure. There was a lot of headings, and they had releases as of June 10, 2016, and then have actual expenditure as of June 10, 2016. So I'm guessing you can clarify if the releases means committed and the actual is what was spent. But I looked at it and I saw there's one particular area which was number 26, which is under the non-profit institutions, which is the Oasis Drop in Hope. And they have for 2016 the estimates to be $266,000. However, the actual expended was $2 million. And I find it's a typographical error. I was hoping that
$200,070. Yes. Apologies. So that the utilization rate is 75%, not 750.
Okay. Well, yes, we would hope so. But on that same table, there is a lot of areas that there was no expenditures. For example, the World Federation for Mental Health, which is an international body, because earlier Dr. Messier spoke about international bodies like the PAHO. So I was wondering if we are not going that way anymore. And before you answer, there's also another concern such like that, like the household section, which is 007, and I looked at the compensation. I don't know who these compensation is for, so maybe you can very share some light to the committee on that, but there was no funds released to date or expended, but I saw there's an estimate of $350,000, so I don't know how many persons that will be covering. And again, for the substance abuse rehabilitation centers, there's nothing, there's a very small amount of the actual that is actually allocated. So if you could just share some light on this particular table that was submitted. It was a lot of data, a lot of headings. So just for us to get some information for us to prepare our reports. Thank you.
In terms of the World Federation for Mental Health, it's a registration fee. So that is why it's $300, and it probably just it's not the time of the year yet when we would do that. Right? Yes. In terms of under households 07, I was told that this covers any claim for workmen's compensation. 07 households, you asked about compensation? Yes.
So that there's no persons that's
Not at this
allocation?
time. Not at this time. So you would only use it when you need to.
Also on this table, there is a lot of transfers to the regional health authorities in terms of millions of dollars. So we have 113 million, 580 million, 247 million, a lot of different RHAs. And from discussion, I heard of a group that is looking at the ethics, the practices, the mortality rates of all these systems to make sure that our RHA is sufficient for our public. And after calling these large figures, and we know the shortcomings in our present public domain, it is not a secret. What do you as the PS estimate, because you are the overseer of all these areas, what do you think would be a fair amount to say that we can fill the gaps or close all these shortcomings from this amount that we see?
Okay. It is. I don't know that I'm expert enough, the gaps that you are talking about. Because first of all, let me say that these amounts that you are seeing here under item 02 to 01, you're seeing 01, and that would be funding that we would provide as reimbursables for some of the authorities' operations. So they would fund things like the gynecological and cancer screening, the AIDS to nursing program, vacant posts, private institutions, that is if they have to outsource some services. The 02 to 05, that is actually what they get as their subventions for the for employment as well as the purchase of items necessary to provide service. Your question as to the gaps, are you asking about in terms of funding? That is an extremely difficult question. Each year, the authorities would bring to us what their plans are in keeping, that would be in keeping with the ASAs, the service agreements. You would find, for instance, that Northwest, because they do a lot of the cancer care, and the cancer care drugs are extremely expensive, that they would have in certain areas more of a requirement. I think that from what I've learned, at the end of the day, we have to decide how we are going with care. We do recognize that at this time, we are in a situation where there is a heavy expenditure for tertiary care because of the ravages of the NCDs. So tertiary care is expensive. We can spend as much as we can get. At the end of the day, though, we have to determine how we are going to get the health of the nation back on track. I am not in a position as a, what would I have to be, a health economist, Mr. Smith? An actuary, to be able to start a health planner to talk about what we can, what the financial needs are.
Okay, let me help you a little bit. The reason I asked is because from the submission, the PS is to look at monthly reports from the director, the finance, and the accounts, and the status of both the work and service programs and financial allocations of actual expenditure. So I'm guessing for all these groups, you would have this financial data. And from this table, the summary table, you're seeing such big variations by the different authorities. And will you just enlighten me that is because of monthly staffing and employment and purchase of items
and size,
right?
sheer
So obviously, yes,
size.
the size. So we know we as a public, we know that what we face when we go to these RHAs, the cost already is a lot. We have spoken about value for money before, and that is why I was asking that. Is there anything in terms of value for money that you can see and highlight?
I would say that we continue to use the systems that we have, so that through the Health Policy Directorate, they deal with the ASAs, they look at the utilization reports, which is more on the clinical side, the actual services that they provide. Every month we get the expenditure reports. We will look at it and see, we can at this stage see what jumps out at us, what major changes there are, and ask a question. And in at the beginning of our committee meeting, we had spoken about the establishment of the re-establishment of the Quality Council with the three major areas: policy, clinical governance, stroke adverse events, and the customer care satisfaction. Those are the systems that we have in place right now, in addition to our monthly whole of RHA system meeting, where through just learnings, sharing, and I think discussion about issues and how we can improve, maintain and improve our standard and our quality of care. But it is an ongoing challenge. It will not be resolved overnight, and we continue to do what we can.
Thank you. Yes, Member Duki.
Thank you, Madam Chair. To the Permanent Secretary, how do you evaluate the value for money you derived from the financial support you offer to your non-profit institutions? Yeah.
The non-profit institutions. That's the question to Mr. Jaising.
Thank you, Member, for the question. We have categorized the set of NGOs, which is about 27 NGOs after the version of it, into certain categories of benefits. For instance, there are about 6 NGOs that deals with chronic disease. There's about 6 that deal with drug rehabilitation services, and another 5 that deals with services to children, HIV, and then maternal and child health. So based on our health priorities, we have aligned the NGOs, the benefits of the NGOs, to that health priority itself. So there will be a match between, but we know at the end of it all, the public system cannot deliver the type of services. So with the assistance of the NGOs in alignment with the health priorities, we are looking at the true benefits of the program itself. For instance, just for one instance, we look at the Trinidad and Tobago Cancer Society. They provide assistance to in terms of services too. For instance, in pap smears, they look at 8,000 in last year, examinations 382, and ultrasounds 2,600. Just to give you an alignment how they provide services other than the public system to our system itself.
But there's a system in place to ensure that you are satisfied that you are receiving value for money.
Well, there are checks and balances in terms of also looking at periodic site visits, right. And also in our MOUs with the NGOs, it is clearly defined that if they don't submit those reports, we will hold the payment part of it, at least 50%. And also we look at assessment of the service and re-evaluating the need of the NGO itself, basically.
Good. And one more, Madam Chair, quickly. Or would you like me to wait for round 2?
Are we still on transfer and subsidies?
Yeah.
Are you going off of the item of the NGOs?
Yes.
Yes, but if I could just
no problem.
Permit, thank you, Member Mark. I believe you had a question on NGOs, and if we could just limit it to the NGOs question.
Yes, thank you, ma'am. Thank you, Chairman. I'd like to ask the PS a few questions, and again, you can generate these responses in writing and or give us a summary plus something in writing. First of all, through the chair, how are non-profit institutions identified for funding? As the first area I'd like you to clarify. Secondly, how does the permanent secretary ensure accountability and transparency with the allocation of funds to these non-profit institutions? How does the ministry ensure that the services provided by these non-profit institutions are provided equitably to all citizens? What mechanisms are in place to identify and reduce fraud in non-profit institutions that receive funding from the ministry. And are these non-profit institutions receiving funding from other ministries and or state agencies? And the last one, how does the permanent secretary ensure accountability and transparency with the expenditure of public funds in these non-profit institutions or organizations? Madam Chair, these are the areas I'd like the Honorable, the PS rather, to clarify, and if she can generate those answers in writing, but for purposes of efficiency, she can give us a tight summary of her responses.
You see, Mark, that the PS would have been able to answer orally, but if they were given one by one. And really, I have to apologize to Member Duki because I really thought you had a question and not a series of questions. But we understand. And therefore, might I ask the PS, I think you have taken a note of the questions. Is there anyone that you can answer now? I mean, the one about fraud with respect to the agencies and accounting for other revenue, other sources of revenue, maybe answers that you were in a position to give at this time.
How are they identified for funding? Mainly because they have to be in alignment with the ministry's own strategic objectives. So they have to be aligned to what we are trying to do, and they have to be able to provide evidence of how the services will be offered and be able to improve and promote the health status of citizens. It must be that they are able to provide the service at a sufficient capacity where it is not being offered by the Ministry of Health. So it mustn't duplicate, but it must complement. The agencies must have a certificate of incorporation, some of the things we require to ensure too that they are bona fide. They must have a list of board of directors with names and positions, the positions they hold and organizational structure. They must produce audited financial statements for the last 2 years. They must produce a strategic plan. They must be able to bring a breakdown of their budget and also the minutes of their last board meeting or AGM. They also have to bring letters to show that they don't have funding from any other ministry, but we will also do our checks. I think in fact there was one that in the recent past was receiving both from social development and ourselves, and we have since stopped because it was more aligned there. We would then have a committee and forward the request for subvention to the evaluation committee. The support team, the technical team would then review the allocation, the submission, particularly in terms of the subvention that is being requested and the funding. They would have, again, some of which I called out already, the criteria that they would be looking at. The chairman of the subvention evaluation committee would convene a meeting to assess and evaluate the request based on the outcome. A draft note for cabinet would be prepared. Thereafter, once it's approved, a memorandum of understanding between the Ministry of Health and the NGO will be prepared and signed off, and funding will be disbursed based on what is agreed in the MOU. The agency is also required to report on a quarterly basis to the Ministry of Health. So far, what we've been doing, we have been doing site visits. As I said, we do the quarterly reporting, and if there is any issue related to compliance or query on the quarterly report, the ministry may withhold at least 50% of that quarterly subvention while matters are being dealt with. But would you like me to go on, or would you like me to produce the rest in writing?
Yeah, I think, Madam PS, you can, but we've got the general gist. And to say that that's the reality, that is the policy.
Yeah.
Does that happen in reality?
It does. At this time, we have 27 agencies that we are currently funding. There were 11. I believe that 16 of the 27 currently have MOUs. We are working through with the others to develop the MOUs, right? But we do have subventions to them, and they have been producing reports, but the records had shown that there were no MOUs, so we are fixing that. Of the other 11, we have stopped payment to 7 because the visits, and they weren't compliant. So that I would say that the system is working. As we have talked through some of the other things relative to fraud and the strength of the internal audit system, there will always be room for improving and looking at your systems. But I would say what we have in place right now, it is good. It is good, and we do believe that the partners who are funded and providing services through these subventions really do complement the work of the ministry and provide good support to the citizenry.
Thank you. Member Bashk.
Reference is made to item 007 households, in particular medical treatment of nationals in institutions. I see in your submission the actual expenditures of June 10th, 2016 is over $37 million. Can you inform the committee on who benefits from this program and how are patients selected?
For this program, and I would like the committee to be clear that this program is not under the EPP program, but it was a different program that was in the ministry before. Where there have been issues in the RHAs in terms of being able to deliver care, the ministry has used this vote to assist with the provision of eye surgeries, the provision of prostheses, cancer co-payments, and other services as may be deemed urgent and necessary, and some one-time grants for citizens who have urgent need for medical attention. So far, for the period April 2015 to March 2016, some 811 patients have benefited from this program. In the case of prostheses, the 245 patients, and we had found that that was an increase over the previous year of 146. And what we had understood is that the Ministry of Social Development had a similar program and they had stopped. I think all ministries were trying to realign and ensure that their programs were more relevant to the kinds of services they were providing. So that, as I said, since April last year to March, 811 patients have been assisted under this program.
My question really is how are they selected? Is there a standard procedure or? Please.
To answer your question, member, I'd also like to add to what our Permanent Secretary would have said. Under this medical treatment for nationals, we also do the payment for cancer treatment to all nationals. To access the services of what we refer to as medical aid, the patients go through the same process of applying through medical social workers and being financially assessed. They are then recommended to the ministry and submitted to Permanent Secretary through the Chief Medical Officer for approval of the Honourable Minister.
Member Duki.
This has to do with health centers. Let me see if I could pose it like this. Are people in large numbers engaging the hospitals for services that can be effectively rendered at the health centers and thereby straining the resources of the hospital and leaving resources at the health center underutilized? Is that happening?
I think that historically that is what was happening. There is still a degree of that happening, and a major factor that contributed to that were the hours that health centers opened, and I think that is why the policy for extended care at certain health centers had been put in place. The RHAs have reported that there has been some degree of lessening of the burden.
But is it significant?
The jury is still out on that, because we have been trying to collect data over the past few months to really look at the trends to see how significant or not that is. We have been getting reports that the people who have utilized the service have been pleased that because of the convenience, and this was a major factor that would have contributed to go to the decision to go that route. I think, though, that culturally, we are people that run to the A&E first. We don't really think about going to a health center. It does require continuous conversation and communication with our public. As I said to your specific question, we are currently collecting the data from the RHAs to determine, in fact, how effective then the extended hours policy is being, because a key aspect of it would have been to reduce the burden on the A&E. So that is still out and under watch. That is what I can say at this time.
I just hope we could get some more information on that as we go forward.
If I may, Chair, Mr. Smith would like to add.
Thank you.
Honourable Member, just to add to what the PS is saying, which is very accurate, we're in the process of analyzing the data in terms of utilization. The only other point I would like to add is that the health system in terms of our primary healthcare services is supported by what we call district health facilities. And these district health facilities carry as part of their service an accident and emergency department, which is 24 hours. So we have the capacity in district health facilities such as Arima, Superior, St. James, the Couva District Health Facility, Mayara, and so forth. What they will do is, in fact, patients still have access to primary healthcare services and accident and emergency service on a 24/7, 365 basis. And if when they go there, the services that they require need to be escalated, we can do what we call stabilize and transfer using our ambulance network services within our RHAs to take them to the major facilities such as Eric Williams, San Fernando General, or Port of Spain General. So it's a combination both in terms of healthcare services of general practice and the district health facility.
Thanks. Good.
Thank you. And Dr. Buddha, just before I take you, I believe Member Mark has a final question, and if it could be put in a way so that the PS could answer, please.
Yes, PS, Permanent Secretary. Where would pharmaceutical products fall? Would it be on the transfers and subsidies where you have to allocate funds to C40 through NIBDEC, or under development, your development program, or is it going to fall under the IF, Infrastructure Development Program? Where would pharmaceutical products fall in terms of our discussions under these three headings?
Sorry, thank you. It is not under not under the GP. It is under recurrent, but let me just get the exact vote for you. It's under goods and services,
Okay.
02.
Thank you very much. Might I then ask Member Boodoo?
Thank you, Chair. Madam PS, just a few areas for clarification under transfers and subsidies, and some simple questions really. And if we could just refer back to the table. And I just want to clarify something with regards to the allocation to CAFA. And I know CAFA has been a valuable partner to the Ministry of Health. But my question really, and I note that the Caribbean Regional Drug Testing Laboratory is now part of CAFA. But my question really relates to the issue of, in the public domain, the public concern regarding fake drugs. Can you confirm whether, in fact, the Ministry of Health has at its disposal facilities for what I would call drug efficacy testing, if that is so, and if that is not so, whether CAFA may have some role in assisting the Ministry of Health in dealing with this issue?
It has been in the public domain that the ministry's laboratories for the Trinidad Public Health Lab had been subject to fire. We do have facilities that are being refurbished on the CAFA compound. We do have testing done by CAFA, and in terms of the chemistry, food and drugs, some testing is done by Kariri. Is Kariri? Kariri, yes. Okay. So that, that is how, until we get our labs back up and running very soon, that we are continuing our regulatory requirement.
Would you venture to give a time frame to very soon, PS?
Well, I do know that we were getting some fire tests done, so it's kind of winding down, thankfully.
Thank you.
Thankfully.
All right, so I'll just move on again in the same table with reference to PAHO, and again a very valuable partner to the Ministry of Health. But my question really relates to the fact that the Minister of Health recently indicated in the Parliament, in response to a question on maternal deaths, that PAHO would be engaged to assist the government in its battle to further decrease maternal mortality, as well as the development of protocols for managing women with Zika in pregnancy. So can you indicate to the committee, PS, whether this engagement with PAHO has in fact taken place? What was the outcome of the engagement with regards to maternal mortality? And the third question would be whether any protocols are now in place for managing women diagnosed with Zika in pregnancy. And if there are, can these be shared with the committee?
The short answer is yes, both to training and assisting with the protocols. And if I may, through you, Chair, ask Dr. Nasir, our CMO, to elaborate, given that the clinical nature of the question. Thank you.
Thank you, PS. So let me answer the last question first with respect to Zika. Yes, we do have a protocol in place for management of women with Zika in pregnancy, and this was done with the facilitation of PAHO experts internationally that were brought here to facilitate our local specialists to come up with the protocol. And that, like most protocols, it is up for review as the Zika epidemic unfolds further. We do have a repository or registry where we are compiling all the cases of Zika in pregnancy. We are monitoring them closely. We are doing the serial ultrasounds and so on, all within the guidelines of our protocol. Now, with respect to maternal mortality, yes, we have engaged the services of a number of specialists through in the PAHO region, in Latin America, the Caribbean, and in North America that have visited Trinidad and have been working with our specialists in terms of using different techniques. Now, one of the most common causes of maternal mortality, as the member would know, is postpartum hemorrhage. And recently we had a number of workshops in the different regional health authorities with the nurses and with the physicians, with the obstetricians and so on, showing them different techniques that they may use in an effort to minimize the blood loss post-delivery. And all of these are beginning to show results.
Just one follow-up, Madam PS, with regards to that. I know the issue of the Director of Women's Health has been on the table for a while. Can you indicate when that position will be filled?
The recruitment process is almost complete. There were interviews for the position, and the preferred candidate was identified. I think an offer and so is to be made at this time. So again, like the labs, very soon, thankfully.
Thank you, PS. Just one more item on that table, and that regards the entities under 01 RHA, where the budgetary allocation was, I believe, 360 million. But I just wanted to go through a few items in the breakdown with regards to that. And the first would be the emergency ambulance service. And just so we have clarification, because we have the emergency ambulance service under that allocation, but I also see a national ambulance service lower down in the table. So if we can get a clarification as to whether it's two different services or are we just referring to the emergency ambulance service?
Emergency ambulance service, which we know about, that is outsourced to GMRTT. The National Emergency Ambulance Services Authority is the authority that was set up to have oversight of the ambulance service. To the Act, there's a National Emergency Ambulance Act, so the authority was set up under the purview of that Act.
So is there going to be a relationship between the outsourcing and this authority, this new authority?
Well,
I'm just trying to understand.
Okay. At present, the ministry has a contract with the GMRTT, right? But that would have to be transferred to the authority.
All right. Regardless of how it's administered, Madam PS, my concern, and I'm sure the concern of many citizens, would be really what should be a citizen's expectation in terms of when a phone call is made for an ambulance service?
Madam Chair, a question relating to that was responded to by the Minister of Health as question number 34 in the Senate, but I can't give the gist of what that response was.
I appreciate that, please.
Okay. We do know that there had been instances, and they were well reported in the media, of poor service delivery. Since that time, the Ministry of Health had collaborated with GMRTT and the RHAs to improve the service. At the point in time, there were records that a patient could be waiting for about 40 minutes, sometimes an hour, sometimes more. A number of strategies were put in place, and that service now is about 20 minutes. It has been cut down to, so that between the collaboration and communication between the GMRTT and the RHA, they have instituted systems to allow for quicker patient handover This has to do with how they will triage registration, as well as the RHAs had got new trolleys. They had increased the number of trolleys, so patients, they didn't have to wait on the ambulance trolleys. There was also put into place a system for phone access by GMRTT supervisors to the managers of the emergency departments should a van be waiting more than 20 minutes, so that they would step in there. It has been found that this move from 40 minutes, the general 40 minutes to 20 minutes, is the equivalent of adding 3 ambulances over a 24-hour period. The situation continues to be monitored by the ministry, and again, it is one of those topics that will come up at the RHA monthly meeting that we hold. But I think that it certainly has been a situation where we've been able to improve and really meet, for the most part, the expectation of the client.
Thank you, Madam PS. Just to go down that table, and if I could stop with the AIDS to Nursing program, yes. Can you indicate to this committee whether the AIDS to Nursing program has been found of value to the health sector and whether it is going to continue?
AIDS to Nursing program, I believe that is on the order paper for Friday.
Is it? Wasn't aware of that. Okay, so
a particular question has been put with
yes.
respect to that,
yes.
and therefore,
right.
not to anticipate that.
Sure, not a problem.
Yes.
Thank you, Madam PS. Just under that would be the item of vacant posts. So if I can ask, Madam PS, if you can you indicate how many vacant posts exist in each RHA for house officers, registered nurses, and other health sector workers? I'm not sure if you can give us that figure.
I would wish to provide that in writing,
sure.
Please.
Are there any plans to fill these vacancies? And if so, what would be the timeline for hiring these staff?
That as well, I wouldn't be able to answer that question for you properly. I'm sorry, Chair.
Okay, thanks.
Chair.
And just the last item there, I just want to go back to the issue of legal fees, and I know Member Coffey would have asked about that. But in terms of legal fees, and it's a big issue because, there's an increase in medical legal claims, not only in Trinidad and Tobago, but worldwide. And there is a practice in some countries now where there's a ceiling, where some countries have put a ceiling in terms of what the court can award and so on. And again, sometimes when these matters go to court, the aggrieved individuals don't always get justice in the true sense of the word. So is the ministry giving consideration to a policy of what you call a no-fault compensation scheme and to impose a ceiling on court awards? Are you in a position to answer that?
No, I'm sorry, I'm not, but it is something that I certainly can take back to the ministry to determine whether it's something that we should put on the table if it isn't there already, and I just don't know about it.
Thank you, Madam PS.
Thank you very much, members. I think maybe we could now spend a little time with the ministry with the discussion on the Consolidated Fund and the IDF. Okay? So that, yes, the Development Program Consolidated.
Yeah. Mm-hmm.
Yeah. Member Webster, I think you have one final question on current. Okay, fine. Thank you. So we now on the Development Program Consolidated Fund. Thank you.
In your submission, initial submission for March, under D005 tissue transplant, you said you had an expenditure of $135,154, and that initiative was 50% complete. I'm looking at your most recent submission where you stated now that your expenditure is actually $568,321. Describe what was done in the time frame that would have arrived at a 50% completion as your status, and where you are now.
Okay. What I have here as actual expenditure as of June 10th is 309,131, right? And with the outstanding commitment, it goes to 568. But I know that it is to be utilized for an upgrade of the lab and procurement of equipment to establish a corneal bank, so that some preparatory work continues to be done at the NUTU, as it's called.
With an expenditure of $135,000, you're 50% complete.
That would have been an error, and I offer my apology.
Okay, thanks.
Member Coffey.
Thank you, Madam Chairman. I'm just trying to see whether I'm reading correctly. I'm dealing with your submissions under the development program. The second question asks for a description of how the funds assist the ministry in achieving its strategic initiatives. The third question asks about how the allocations meet the needs of the ministry and contribute to the improvement of its performance. Now, I'm looking at your response in that area, and it says the allocations requested are based on the desired strategic priority outcome and the work plan for each division. I'm trying to fit the Couva Children's Hospitals into a strategic initiative of the ministry, because in the previous question you noted that most of these projects are for hospitals. And what strategic initiative did the Couva Children's Hospital meet? I'm talking about the location. For one, you had already the Wendy Fitzwilliam
Pediatric Hospital.
Right. And was some study done that showed that that was not meeting the needs of the population or sick children, and on that basis a decision was taken to side the hospital in Couva and to expend the significant funds in that regard. I'm asking this, I know you're not a politician, I'm asking you this in terms of ascertaining the how you arrive at the strategic priorities that would lead to this expenditure of funds for that facility and all the other facilities that you expend money on.
Madam Chair, that is a very difficult question. I'm wondering, if I may, with respect, if it's a fair question.
It's a question simply based on your submission that the expenditure is based on the ministry's examination and identification of priorities based on some kind of study.
I would venture to say that at the time that it was a decision, the decision was taken to do it, that it would have been seen as a priority for the ministry and for the country.
If I may intervene, we are really looking at expenditure for 2016. And in terms of, if I look at the submission, this is F006. And in terms of 2016, and I'm just tying it back to the question you've asked, Member Coffey. If I read this correctly, I see nil under releases, and I see nil under actual expenditures June 10th, 2016. Am I correct?
Yes.
Okay.
It's under commitment.
Outstanding commitment as of June 10, 2016 is some $15 million. And maybe what might be easier for the PS to address is this commitment relates to what period?
It relates to expenditure incurred in the last fiscal year and some from this fiscal year. I know that it would appear because we have no releases and you have commitments, but the way the IDF operates is that you have your allocation, and once you have your bills validated and all other requirements, as set out under, I think it is circular number 12 of the Ministry of Finance, you send your request down and they then provide the release based on the validated bills.
Okay, so can I ask what was the expenditure in 2016?
It would have Okay, I wouldn't, okay, one, there would have been bills related to the project management, and so this project came over to us from the Ministry of Housing. We have now started to get the bills, get them validated, because the money is actually under us now, and the project was transferred to the Ministry of Health. So that the bills are coming in, we're getting them validated by the Ministry of Housing, and then continuing the process for payment to the contractor. I don't know if that confuses it more.
Yeah.
Yes.
So it wasn't originally your project then?
It was not originally our project. In the last fiscal, it had been under the Ministry of Housing and Urban Development.
So, given that it wasn't your project, it didn't satisfy all the criteria that you mentioned here. This was just handed to you. That's what I'm trying to figure out.
I respect your opinion.
No, it's a question. It's not an opinion.
Put a question mark on it.
Thank you, Madam PS.
Dr. Budu to ask his question.
Thank you, Madam Chair. And Madam PS, as your mind is focused on the Cuba Children's Hospital, I'll just ask, and there are just three simple questions I want to ask with regards to that. And the first is whether you can indicate if the work of the commissioning team that I believe was appointed perhaps in June or July of last year by the Ministry of Health, has the work of that team been completed? And if not so, if you can indicate the status of that work. And the second question would be, can you... Sorry. Okay.
Can you allow the PS to answer, please?
Okay. As far as I'm aware, the work is still ongoing by the team, and we continue to look to see what needs to be done to enable commissioning of the facility.
Okay. Madam PS, can you share with this committee a list of equipment that is currently installed and available at the Cuba Hospital?
I would
in
wish
writing.
to, yeah.
Yeah. And the third question really would perhaps come back to the first, and is, can you indicate to the committee of plans, or the Ministry of Health's plans, for the operationalization of the Cuba Hospital and the expected start date?
Well, I would say that my last information is that the contractor has asked for some more time because works are still ongoing on the site, so that even while the project has been transferred to the ministry, the facility hasn't been handed over as yet. So that in terms of a startup date, that is not available at this time.
Thank you.
Member Kafi and then Member Mark.
Under the development program, I'm seeing an allocation for the Scarborough Hospital construction of 2.5 million for 2016. Could you explain? I was under the impression that that was completed and handed over, and could you explain?
The complete payment. The project is completed, but it was to facilitate the outstanding payment for some equipment. Specifically the MRI and the cardiac cath lab.
Member Webster Roy.
Thank you, Madam Chair. Through you. Under D007, waiting list for surgery, senior allocation is 11 million. Your expenditure and commitments as of June 10, 2016 is 17 million. The projected expenditure is $30,834,900. Could you just explain that to me, please? Thanks.
Oh dear. Okay. I was saying that the ministry has a number of clients to, for whom services to be provided under this, and I would say, member, that the list keeps growing. We are at this time trying to work with what finances we do have. We are also recognizing, as you see, the status of the vote with the commitments. So we have started discussions to see where we may have to move around any money within this consolidated fund to find extra savings to meet those costs. We are also in discussions with the Ministry of Finance as well in terms of releases and so.
Yes, would that also apply to D003?
Yes, it does. Indeed.
Same thing. So that is their policy that once there is, because I think the public would like to know, once there is a need and the public accesses and they qualify, that this need will be entertained and facilitated by the ministry.
As far as possible. As well, we have started working more closely with the RHAs as well to see whatever they can do to really take up some of the slack. Whereas before, if they had certain difficulties, we are also trying to work with them so that some of the burden, more of the burden could be shared. But it is not much more. Additionally, on the dialysis side, in fact, earlier this year, we had a situation where the roof of the San Fernando General Hospital in the area where they provided service for dialysis to patients, the roof caved in, and that immediately brought us in about 110 patients or so, whom we now have to keep on dialysis. You may have noted that we have another project for under 018. That is for the establishment of 2 renal dialysis centers, and that is picking up pace. And this is for Mount Hope and San Fernando. We expect that when those do come on stream, but that, of course, is in the short to medium term, it's not immediate. We will also be able to pull back into the public health system a number of patients. But at this time, we are reliant on our outsourcing to private health agencies.
Thank you, Madam Chair. Looking at the projects and the construction of the dialysis center, the waiting list for surgery, is it fair to say that most of the cases are generated from lifestyle diseases?
Yes, ma'am, and that's the sad reality of it, and it is also why the ministry has developed a plan for treating with the non-communicable diseases. I'm pleased to be able to share that Cabinet has recently approved a loan totaling some $48.8 million from the IDB, which is soon to be signed by the Ministry of Planning. We do have a multi-skilled team in place at the ministry currently finalizing the policy and the strategic plan for the implementation of the NCD program. It is one of our key strategic areas, and that should soon go to Cabinet. Some work is already being done through, I would have mentioned in another context, a PROPEF that is actually a facility that we have from the IDB to do preliminary work preceding the actual loan.
Member Duque.
A general question as it relates to projects that we are discussing right now. What systems are in place, and is general, and if you wish to choose a project to answer, you can do so. What systems are in place to ensure that you deliver within time, within budget, and with the specified quality?
I will share the response with Mr. Coilas, our project manager. The ministry has a weekly strategic planning meeting, and that takes up a lot of where we are with our key projects. And so additionally, the process that is in place between ministries and the Ministry of Planning, where we are required to report both on a monthly basis as well as quarterly reporting. That is another important feature. We do also try in the ministry not to wait on the specific meetings or so, but the culture that we encourage is if you know something is going on and something is emerging, then we try as far as possible to mitigate whatever is. But I will ask Mr. Coilas to go into more detail from the project management side of it specifically.
Good afternoon, members. Just to add to what the Permanent Secretary has said, definitely with respect to the large projects, particularly the construction of health centers and construction of new hospitals, we do engage UDCOT and NIPDEC, who bring that level of project management expertise to the project. From the Ministry of Health, and though we are in fact very much involved in, first of all, developing the user brief together with the respective RHAs, so it clearly reflects the functional requirements in terms of the facility. We also have a clinical infrastructure committee in place, which would meet on a monthly basis with either both NIPDEC and UDCOT to review the progress of the project. So there is that level of oversight which goes on. Both UDCOT in particular, because of the very large projects they do, are required also to have a FIDIC engineer on board to support the construction, administration, and supervision of the project, and also an independent healthcare consultant to assist the Ministry of Health in the review of the designs and the medical equipment. So there is a very close working relationship both between the Ministry of Health and the respective project management agencies that we engage for those large projects. With respect to what we would call the smaller type projects, which are handled at the regional health authorities, They do provide, as part of the PSIP reporting requirements, monthly reports on the status of all their projects. We do have started to have meetings with the representatives of the RHAs in terms of reviewing the progress. And what we have also started now is to do some actual site visits at some of the RHAs in a particular project. So, for instance, for this year, we have already completed site visits at both the North Central RHA and at the Northwest RHA on their projects, and we'll be continuing very soon with both Southwest and the RHAs. So, in a summary, that's the sort of monitoring mechanism which we have in place.
Deal summary. Good.
Member Bash?
My question really has to do with the role of the internal auditor in monitoring expenditures. Presently, who constitutes the internal audit unit?
Unit that is headed by an Auditor 3, and she would have officers under her. I cannot tell you offhand the exact numbers and the designations of those officers.
All right. In your submission to the Parliament, you indicated that due to human resources constraint, the role of the internal audit unit is limited. Can you let us know how many persons are required to achieve the full staff complement of the internal audit unit?
I can provide that information for you because in writing, subsequently when we have to do all the others, because I would have to confer with the HR unit and see exactly which positions are currently vacant.
Thank you.
Member Mark and then Member Ramkis.
Permanent Secretary, are you aware, you may not be, but I think it was on the 2nd of May, the chairman of UDCOT gave an undertaking to Parliament that by the end of May 31st, 2016, the Couva Children's Hospital would be handed over to UDCOT from the Shanghai Construction Group. He did indicate at that time that the liability defect period would end in July of 2016. So I'm a bit surprised that having given that undertaking to the Parliament, that you are now reporting that work is still in progress, and therefore there has been no handing over of the Couva Children's Hospital. Seeing that UDCOT is the project manager of that particular hospital, would you or Mr. Coilas be in a position to give us some kind of indication as to when this Couva Children's Hospital will be formally handed over to the Ministry of Health and by extension the government?
Well, I can give the indication with respect to the first part, which would be the taken over certificate. UDCOT would expect, based on assessment of the works which still has to be completed, the testing of the MEP, there's an access road construction which is still ongoing, that by the end of July of this year, they would be in a position to issue the taken over certificate. Now, there is a process there in that once the contractor is of the opinion that they're ready to complete the works or handover, they need to submit what you call a notification within 2 weeks period. Say, okay, we will now be ready to hand over the facility. They have not yet issued that, but from discussions with UDCOT, they would expect by the end of July 2016 that taken over certificate would be issued.
And that would be the effective end of the liability defect period? No, because what we were told at that time by Mr. Garcia was that the liability period would end July 31st, 2016.
Just remember, maybe you would want to ask the project manager, when would the defects liability period end, based on when you are seeing it is likely to be handed over?
Right. Typically, once the project is handed over, it's at that point of time when your defects liability period starts, and it runs for a period of 1 year.
All right, well, could you, PS, provide us with a status report on the construction of the oncology center? Could you tell us where we are at in terms of the percentage of completion of that project? How much money has been spent thus far, and when that project is to be completed, and what's the overall cost of that project? And maybe you can also give us a status report on the construction of the Arima Hospital at this time, where we are at with that Arima Hospital.
Could you just hold a minute and let's have the PS answer on the oncology center?
Okay.
And then we do.
Okay, right, okay.
Yeah, and again, I will share with the project manager. From my figures, the allocation for this year has been 107, and we had actually transferred some funds to the Point Fortin Hospital because we estimate that we would need 107 for this year, and we needed some funds under the Point Fortin Hospital. So the releases to date have been about in the vicinity of 9.9 million. The actual expenditure as of June 10th, 9.9 million. Outstanding commitment is to about $12,800. And there has been some retrofitting work and so, and for that aspect of it, I will hand over to Mr. Coilas, please.
With respect to the expenditure which has been incurred, at least for this fiscal year, the Permanent Secretary did indicate that based on the invoices we have received and obtained releases for, was just over 9 million. But I think your question also extended to what is the cost to date, is that was on the status? Okay. Well, first of all, the project itself, in terms of when you look at both the design and the construction component, is roughly at 20% complete. There was, as the Permanent Secretary indicated, some structural retrofitting work, which was recommended to the foundations of the building, and that has in fact been completed. Not too sure. Yeah, that's basically.
Oh yeah, what is the value? What's the total cost or the estimated cost of the oncology center to start with, the Arima Hospital, and I also mentioned the Point Fortin Hospital? What is the estimated cost?
Okay. Well, yes, the cabinet approved budget for the oncology center, it's 809,651,070. That's for the oncology center. With respect to the Arima Hospital, the cabinet approved budget, it's 1.853,359,751, so that's 1 billion. And with respect to the Point Fortin Hospital,
1 billion or 1.8 billion?
1.8 billion, sorry.
Okay.
And with respect to the Point Fortin Hospital, the cabinet approved budget for that project would be let me get you the exact figure, 1.5 billion, 1.567, 536, 356.
Madam Chair, through you, could you indicate to us in terms of the oncology center, what percentage of the work has been completed thus far, and what was the total value? Is it 800 million, you said, for the oncology center?
That's the cabinet-approved budget, correct, yes.
Right, and what percentage of the work has been completed in terms of, only 20%?
Yeah, as I indicated, yes.
And the expenditure so far would have been what?
The expenditure so far, I think it was just over $195 million, which would have included aspects of the design fees, construction fees, everything which has been done so far.
Madam Chair, could I ask the Permanent Secretary whether the Rima Hospital has been redesigned from what the Cabinet had initially approved in terms of the 1.8 billion?
No, it
has it been redesigned?
No, it hasn't been.
No.
So the numbers remain the same? 1.8 billion?
As far as I'm aware.
Okay. Thank
you. Member Ramkisoon.
Thank you, Madam Chair. In relation to the submission presented by the Ministry of Health on page 9, number 9, in relation to development projects, I'm quite interested to note how many development projects to date was found to not have been granted parliamentary approval or relevant approvals.
All have parliamentary approval.
Okay, so this answer will be amended?
Yes, we can amend the answer.
All right. In relation to the internal policies and procedures, I know Member Dookie had asked and Mr. Kaulas had given us an insight on all the oversight mechanisms in place for projects. So when I looked at Appendix 6 in Infrastructure Development Program, there was a particular note, and I must say I commend that we rank contractors based on their rating. That is very commendable. And I noticed that a particular contractor was ranked as unsatisfactory, and he had about 1, 2, 3 projects. Oh, wait, he had 1 project here, and he was ranked as unsatisfactory, and that is for the refurbishment of the Ward 2 at the Port of Spain General Hospital. And I could not understand this amount, and I don't know if it's typographical error, but I could just seeking some clarification on this. The sum spent on the contractor, is $1.8 million. Sum awarded is $2.2 million. There's a difference, and I'm not sure why. Can you just shed some light on that?
It says that the sum awarded, it would probably be the value of the contract, because that will generally be they'll call that the award. If the sum spent on the contract, it would be the sum that would have been expended for actual works to that date.
Well, this is 100% completed. So I was just wondering.
I'm not sure what. Okay.
Yeah,
I will
because
have,
I saw,
may I?
Yeah, a couple like that. I saw
Okay.
also the repairs and refurbishment to the X-ray and radiology department. Again, 100% complete. That is overall plan and actual complete, 100%. But yet the sum awarded and the sum spent on contractor was different, and I couldn't really understand why. So.
Okay, and if I may ask, member, you're saying that this is Appendix 6 of our submission. May I relook and put something in writing for you, please? Thank you.
I also have another question on that. In relation to this is the refurbishment, I believe, to the Port of Spain General Hospital and St. Anne's Hospital, and that there is talk of the paving and car park construction. And I saw here they have overall planned percentage 100%, but the overall actual is 0%, and then they have project on hold based on a recommendation to have an the table is cut off, so we can't read it again. So if you could just look at all these issues with this particular submission and resubmit it, we would appreciate it.
Okay, will do. My apologies.
Yes.
One more question?
Yes, and the same, and the submission, I noticed also, just give me a second to find it. This is Appendix 3 for development programs. And it is the hospital refurbishment programs, see Appendix B, but I think you mean 3B, so there's a typographical error there. This particular project was over budget and yet is not completed because I'm seeing it's at 50% completed. So I'm not understanding this figures because I'm seeing here $31 million in 2016 and then $36 million again in projected expenditure. And again, the comment says overall 50% completed. And the approved budget for this project is only $31 million. So we are over budget, but we only at 50%. So
the check, this one was Port of Spain. Tell me which project this was, if you don't mind, please, member. Just repeat for me. The one where you said the 31 and the 36 million, the last one of which you spoke.
Well, the number on it for the project or program is C234. Does that help? C234.
Hospital refurbishment project. That is projects that are ongoing at different stages of completion, and that would be a number of projects under a program of works being undertaken. Outstanding commitments for fiscal years, we have that 15.2 and 36 million, but they would be projects across the RHAs. Projects across the RHAs. You would want to help?
Yes. Okay. Hello, ma'am. Good afternoon, member. Just to confirm, yes, the hospital refurbishment program, these are projects which are undertaken at the various RHAs, they span a number of projects. So, as an example, under the hospital refurbishment program, you would have projects allocated to both the Northwest RHA, ERHA Southwest, and the North Central RHA. So the 31 million would have been allocated across these various projects that were approved by the ministry for the RHAs to undertake. And they would be at varying stages of completion.
This is over budget.
Not with, well, with respect to the allocation which we received for $31 million, if that's what we're referring to.
Oops, sorry, member, if I may, Chairman, through you, one of the things that would have happened is this would be a rolling program, as it were, and I'm sorry that I took so long to get where you were coming from. One of the things is that a number of the projects would have been approved in the last fiscal, and they may have started, for instance, they would have had some of them that might have started with a mobilization fee, for instance. And then when we came into the new fiscal, they would have been rolled over. I am aware that when the new boards came into place, and this would have happened sometime, I think one in January and the others more February, March, that a relook was taken of all the projects that were on the cards to see where they were, maybe to reprioritize, and for those that had been approved, they might have been reviewed in terms of whether we could have, the boards would have wanted to really go with them at that point in time. So you would have had a slow pace of implementation for a number of those projects. As well, when we had discussions with the Ministry of Planning, we were able to get some funding, and we then had to even allocate that funding across some of the projects depending on where they were along the implementation and what kinds of bills were in hand. It is a work in progress. We continue to look at this particular item, but as I said, it is a rolling program.
Madam Chair, through you. Since you're talking about this is a lot of projects, and if you look at the submission for 2015, you're seeing a submission of $15 million outstanding, but yet only $31 million was budgeted for, and yet we already expended $38 million. So that's my concern, because we're supposed to be picking this up, any mechanisms in place to ensure that we have systems and certain policies to ensure that we catch these over budget, because we don't want to have cost overruns at this time in our economy. So that is why I thought this was quite interesting. But if you want to submit in writing to the committee, you are free to do so. They break down so we could understand what it is that you are aware of that we are not aware of.
Okay, if I may. Remember, I would have said too that some of these projects would have been approved prior to this fiscal, and you would have had a start to some as well. And then you would have got an allocation that may have been a lot lower. So in a case like this, you would then have to determine what you deprioritize, what you slow down, where do you have room within the overall allocation to do some shifting, and some of that has been taken place.
Maybe PS to assist us with this C234, if we could get a breakdown of the projects, an idea of start, date, and that sort of thing, because it's just a big category with no breakdown. I didn't estimates or here, so that may lend some further explanation and understanding to us. And one last question, please, member.
Yes, it's in the same Appendix 6, just one more project for you to look at in relation to the upgrade works at the Arima Rehabilitation Center. It was noted in the project stage that the board has accepted the recommendation to terminate this project, and we have spent $5 million, and we only completed 43% of the actual works when we have budgeted $6 million. So we only have $1 million again to go. We only have 43%. Can you just share some light on this particular project for us? Thank you.
This was a project undertaken by the Northwest RHA. They had unending problems with that particular contractor. Attempted to work with the contractor towards resolving a lot of the issues. At the end result, they were unable to resolve it. So the Northwest RHA board took a decision to terminate the contractor.
This stage when they're at least, so the money that we spent, the $5 million, was for
works which would have already been
completed by that
yes.
unfavorable contractor.
Yes, but there was no indication from the Northwest RHA together with the contractor when they would have likely been able to finish the entire project. So based on the assessment, a recommendation was made by their project unit to the Northwest RHA board to terminate that contract because the contractor was unable to give a completion date on it.
Mr. Kaulas, is it that we do lump sum projects in the Ministry of Health, or do we pay contractors based on their completed milestones in this particular project? Because I find it very difficult to understand if you have a poor performing contractor to pay him almost the full amount of almost $6 million, and you're not even close to complete. I find it very difficult to have spent that money knowing that we didn't get what we wanted, or not close to it.
That's correct. Contractors are paid on milestone payments, right, for the work that has been completed.
Okay, so what milestone was completed for this project to be at 5 million?
Yeah, I will have to get those details from the Northwest RHA in terms of specifically what was completed and the payments which was made towards.
Thank you. So PS, if you can just share, do your officers go to these sites and visit them and do a review?
I would say that we are making a more concerted effort to so do. I would also like to add that the project management unit at this time in the ministry is quite understaffed. It is basically Mr. Coilas and one person.
Other controls in terms of, and there maybe QSs or something like that who sign off some sort of, what you call it, there is a certificate before payment. Isn't that a control that exists?
Yes. I am told that the project managers would engage the QSs, but I think, Madam Chair, if I gauge you correctly, is what happened, why did it fall apart? And I would say in terms of both the monitoring at the RHA level and the ministry would have been not as where it should have been at the point in time. It is something that we have recognized. We are trying to do better. I think, as I said, the monthly meetings are helping, the strat meetings are helping, and as well, Mr. Coilas and his only other staff, they are out on the road a lot more now.
It's likely that because we have him here, something is not being monitored.
Well, I would like to say that...
And P.S., I will ask you to answer that question. Yeah, thank you.
Yes, thank you, Madam Chair. I just want to ask the Permanent Secretary in terms of treatment of adult cardiac disease. If you have information that you can share with the committee at this time as it relates to the total number of patients who have benefited from this program thus far.
Mr. Sitaram to give the figures, please.
Thank you, Member. For adult cardiac, the figures from the 1st of October 2015 to the 29th of February 2016 was 985. The figure is actually continuously growing. We have patients who access the services, if not daily, from all of the RHAs.
Right, and could you indicate, Madam Permanent Secretary, the number of patients by procedure and the number of procedures by provider institutions?
That I would have to provide in writing, Member, if I may.
Could you also provide a listing of those, provide a list of referring institutions and or physicians and the number of patients referred per institution, per patient, per physician?
So if I were to ask you, you want the listing of all the patients You want it by institution, which would be which hospital.
Right.
You want us to say which doctor referred them, and you would like us to say which procedures they were recommended for. And is there a period?
Just might I ask, 1 minute please. Member Mark, is it that you're asking when you say listing by name? Or do you want to know 10 patients referred by Dr. X?
Yeah, no,
and
I
of
don't
the
want any
10
names. I don't want any names. I'm not asking for the names. Sorry.
But
If
you
just
want the
the-
name of the doctor who sent in the request?
Yeah. Yeah, the physicians, yes.
Okay.
And the other, can I proceed? Madam Chair, how many patients are on the waiting list as we speak?
That too will have to be provided in writing.
And what is the average waiting time for patients on the waiting list? In writing?
But you mean average waiting time? Because I believe Dr. Misir dealt earlier with the difficulty in determining average waiting time. So are you then asking in terms of those patients on the list?
Yes.
So if there are 15 patients on the list, not by name, by number, of those 15, what is the average waiting time?
The experience before they got.
Yes. Okay. But let me just ask this. If they're still on the list, are we talking about average waiting time because they're still waiting?
well, if they're still on the list and so on.
Well, that's the point. If they're still on the list, we can't ask about average waiting time because I think average waiting time would take into account when they came on the list and when they were treated.
Yes.
So that I think that is a little difficult. So maybe what you want is the number of patients currently on the waiting list. Or maybe what you want is, if you take a date and say as of this date, how many there were, and as of this later date, how many there are, you would then have an idea of how many were moved off. So I don't know if that is really the type of information you want. Because average waiting time in the scenario can't be given.
Yes, I realize it's going to be challenging based on what was advanced to us. But I'm saying that those who were successful in the exercise, you may wish to share with us what is the average time they took to realize that at least the care and the program itself was administered within a period of, let's say, a month or two. You will be able to determine that based on the fact that you are in charge of this process. But I agree with you, Madam Chair.
And we're really looking at fiscal 2016. Yes?
Thank you. And this is the adult cardiac treatment. Just making sure. Okay. Thank you.
And I've heard in the interest of time, Member Webster Roy has withdrawn her request for a question. So kind, Member Coffey.
Thank you, Madam Chair. I get the impression from reading your submissions that there is a capacity problem at the ministry in relation to all the projects that you have ongoing. And so it speaks to having to reprioritize based on the allocations that you have. For example, you have an allocation for the oncology center, and you have to use some of it for, I think it was Point 14. And now the oncology center is a long-standing project that is 107 million. I'm not sure whether the 9.9 is the spend this year or over the period. But the question I'm asking that given the number of projects that you have and the allocations which don't cover the your requests for the year, does the ministry have the ability, one, to handle all these projects as projects and facilities under construction, and when they are completed, does the ministry have the capacity to man all these hospitals, centers, especially given our economic climate now as it stands?
Thank you, Member. In relation to the capacity of the ministry, we do have in some areas of our HR, we do have some challenges. I will share that the ministry currently has a 6-year plan that you may know about in your other capacity, and we are hoping that that can be sorted out very soon, and that we will be able to get the numbers into place. That will take care of some of it. In relation to the reprioritization, because of the funding constraints, yes, that is happening, and it is a fact of life at this point in time. In relation to being able to man some of these facilities when they are completed, under the PROPEF that I discussed earlier, which is part of our whole IDB program, we do have a 10-year manpower plan that is being finalized, and that will help in some way to tell us what we need. We are also of the view that, let us say, for instance, with Point and Arima, where they are, we'll be in a better position to be able to man those as they come along, and not have a gap. So that all in all, we are seeing that there are some positives. We are working with what we have at the moment, but we think that things are in place to be better.
Member Bodo.
Thank you, Madam Chair. PS, I just wanted to clarify a few items on the development program, and perhaps we could start at the very end with the F001 with regards to the upgrade of the C40 building at Chaguaramas. Can you indicate the nature and the purpose of this upgrade? Yes.
Member, as far as I'm aware, it is a fire alarm suppression system and to improve the cold storage facilities down there.
PS C40, with C40 comes NIPDEC and the arrangement in terms of drugs and supplies to the institutions. And there's been issues about the frequent shortages, and I use shortages in inverted commas because it may be a demand and supply situation. But are you satisfied that the current arrangement between NIPDEC and the Ministry of Health provides for the timely and efficient delivery of drugs and medical supplies to the RHAs?
And member, that is a discussion that is ongoing in the ministry. It is multifaceted, and the ministry is currently seeking to take steps to improve all of the aspects relative to the procurement and management and supply and distribution of drugs.
Have those discussions looked at perhaps an alternative arrangement, or is it attempts to tighten up the same arrangement, or other options being looked at?
Member might be aware that there was a company that was set up, and from what I saw of the policy papers, it was intended that that company would have looked at the supply of pharmaceuticals. Unfortunately, there was nothing beyond the policy decision to put that in place. So we are currently We do currently still have the arrangement with NIPDEC. At this time, what the ministry is doing is working through all the aspects to improve that service and that partnership between ourselves and NIPDEC.
PS, how soon can the public expect this to be a thing of the past?
It is a work in progress, member.
PS, if we can, I'll just move backwards if we may, and just to go back to the oncology center. If you can tell us briefly what services will be available at the oncology center. I know Mr. Stewart would be in a good position to answer that. Just very briefly.
It's a comprehensive oncology center. It's an ambulatory care unit. It consists of 4 bunkers in terms for radiation therapy. So I spoke about before linear accelerators. So it will accommodate 4 linear accelerators. We have a gift from the Phoenix Park Gas Processors Limited, which was accepted by the government, the cabinet, for a PET CT and an MR. So it will also have diagnostic capacity in terms of treating. In terms of its chemotherapy services, it comprises of 21 chemotherapy chairs. It also is equipped with a full laboratory, a diagnostic laboratory to do point-of-care testing, to facilitate radiation and chemotherapy treatment, as well as it has a shielded operating theater that would allow for basic breast biopsies, for example, and other procedures such as, and it will also accommodate our HDR brachytherapy. It accommodates 2 CT simulators for the treatment planning of radiation patients, and it also houses a training facility and administrative facility, as well as pharmacy and support services, including social services, psychological services, and complementary medicine.
Thank you, Mrs. Smith.
And outpatient services, of course.
Yeah, thank you. P.S., with regards to that, in the interim, we do have an issue with patients waiting for chemotherapy and radiotherapy. And CMO mentioned that there was a standard in place where surgery, for example, for breast cancer, there's a 1-month minimum time. Can you indicate what the waiting time would be for a patient who is awaiting chemotherapy and radiotherapy currently at the St. James Radiotherapy Center?
I would have to get that information and supply, please.
For both chemotherapy and
chemo and radiation, you asked.
Yeah. Is there?
You have? You can summarize.
At this point in time, patients requiring radiation therapy, this is accessed through 3 sources. One is that we still do some radiation therapy at St. James. The other 2 areas we have been accessing radiation therapy is the two centers, one in South and one in Port of Spain. And as was mentioned before, we have a clinical assessment committee that meets monthly, and we review all the requests for radiation therapy, and most of them are granted at this point in time. And the waiting time is a month.
That's the answer I'm looking for. Thanks. So if we can just, sorry, before I leave the oncology area, there has been debate about the shortage of chemotherapy drugs and so on in the national forum. Can you, PS, confirm whether that in fact is an issue, or patients able to access the prescribed drugs on a regular basis?
It is so that from time to time there are shortages, but from what I understand, and I'm going here by with the medical jargon, but there are, and Dr. MSYA will help me out, there are 2nd and 3rd line drugs and that are available, and therefore their care will continue as far as possible. Dr. MSYA, if you wish.
To elaborate further, what we have set up at the Ministry of Health is what we call our Oncology Therapeutics Committee. That it looks at all aspects of cancer treatment, put it simply. So what we have is that we have a number of regimens that we can use and we do use depending on the availability of the different pharmaceuticals or the different drugs, so that at no point in time the treatment for a cancer is compromised if there's one particular pharmaceutical that is unavailable. If it is not available, then we will institute an alternative regimen so that at the end of the day, the patient care is not compromised.
So CMO through UPS, are you giving these patients the assurance that they are still getting the required
care that they need?
If I can just move on, I know we had touched on the hospital refurbishment program already, but I just wanted to ask about two projects. And from the initial submission, they appeared not to have been started or in any way, but I was asking about at the San Fernando Hospital, about the status of the project for the refurbishment of the labor ward. Perhaps Mr. Coilas can give me an update on that.
One of the main works which has to be done in order to facilitate the refurbishment of the labor ward.
Labor ward and the neonatal unit, if I may. I know it's a joint project.
Right. One of the things that's involved in it is the repairs to the roof itself. So they have started actually in terms of relocating aspects of the ward, because once you do that, then you have to replace the roof. So the aspects in terms of the start of the relocation has started for some areas. With respect to the roof component, they are currently developing the scope of works in terms of replacing the roof for that area, because I think that's the major problem which was affecting that aspect.
Yeah, the other issue would be the issue of the replacement of the chillers at the San Fernando Hospital. I know last year there was an incident where the chillers went down and the operating theaters were non-functional for a period of time. Can you say if that contract has been awarded, or what's the status of that?
Okay, one, that's a project which they did put forward for this particular fiscal year. We have been able to allocate funds to the Southwest RHA to develop the full specifications. So I know they have taken steps towards engaging a consultant to develop specifications for the chiller. And the main work itself would be done as part of our estimates which we have put forward for 2016, 2017. But the important thing right now is that all the preliminary works in terms of the specifications would be completed.
I just want to go up to the medical equipment upgrade program, and your initial submission, which you have spoken to, I think, March 7, 2013, indicated that a number of projects within the hospitals and the various RHAs, there was either no expenditure or they had reached a standstill. And if one were to look at the comments column, a recurring denominator there would have been tenders submitted to the Ministry of Health for approval in many of these instances. And of course, there is a situation where you have the contracts above 1.5 million has to be approved by the Ministry of Health. So, Madam PS, you have a situation here where the contracts are approved by a board and then comes to the Ministry of Health to be approved by another tenders committee. So can you state how many contracts approved by the RHAs are currently awaiting approval by the Ministry of Health? Sorry.
Not offhand, member, but if I...
Can we have that in writing? Yeah. And can you also indicate how long these contracts have been awaiting approval? And further to that, Madam PS, do you agree that this process of having two tenders committee review the same contract, do you agree that this is responsible for perhaps significant delays in the procurement of goods, services, and infrastructural improvement, with all due regards, of course, to oversight and so on?
Yes, and that would be the main function of that committee. It would be concerning more oversight. They would want to more look at the procedure and the process that would have been undertaken, so that it is not the same as another tenders committee. It is, if you want to say, a gatekeeping committee more to satisfy the ministry that all the required processes and procedures and transparency have been met.
Thank you, Madam PS. And whilst I understand that, and with all due respect, and if I may just, take one example in Appendix 3A, where, for example, under the NWRHA, you had the issue of the supply, installation, commission, and maintenance of 12 CTG monitors for the maternity department. And this is a situation where we are trying to improve maternal mortality and neonatal mortality, and yet, as of the submission on March 2016, there had been no actual expenditure tenders submitted to the Ministry of Health for approval to proceed with award of contract. Now, I do understand that you have to have oversight and so on, but do you think there is a place perhaps for, fast tracking some of these contracts, or, or separating them in terms of urgency?
I would not be able to say precisely what would have happened with respect to that particular contract, and we are talking here about the approval at the ministry end, because I would also want to say that early in the year we really were not getting DP releases, so that would have been another issue. I hear what you are saying, and we can take on board whether we can, categorize some things. I would prefer, though, to that request that you had put in to say when things are there and how long they actually stay, and perhaps look at that in addition when considering your suggestion, please.
Thank you, please.
Madam Chair, sorry if I may, Mr. Coiles has asked whether he can also make a comment.
Sure. Well, I'm just pleased to indicate that the Northwest RHS since issued the award for those particular items of equipment, so we would expect delivery very soon on it.
Wonderful. Thank you, Mr. Coiles.
Yes, two questions to ask. In the discussion, we heard under DP and a statement like rolling over of projects. I would expect, my understanding is that projects have a start date and a finish date, and therefore, having regard to the annual call circular that talks about programs that have no discernible date, start date, and scope and so, are there any projects that you may have identified which should not, going forward, be included in your capital expenditure funding?
Thank you for the question. Now, I used as well rolling when I talked about the program as it relates to the hospital refurbishment,
Yes.
which meant that that program, there would always be ones that you finish and ones that are brought on. And in the same way, I think the medical equipment. But what I think I understand of your question, the answer is yes. I have raised the issue that there are some work that we are doing that is funded by the DP that I think should not be there. As an indication, we have the treatment of adult cardiac and the renal dialysis, those programs. Additionally, I had noted that we have what is really a subvention to the Medical Research Foundation that does a lot of work for us in HIV, and yes, D001.
Yes.
Special program HIV/AIDS, and that is really the medical for treatment,
Yes.
and that is ongoing, and that has been there for a number of years. So I have flagged that we will wind up the discussion at the ministry, but I had also raised it with the Ministry of Planning and the Ministry of Finance that we would probably want to have a conversation concerning those particular votes.
Okay, thank you. And P.S., in terms of the conversation thus far has really gone with us asking for sort of clarification and so on. And I think we should really invite you to tell us in what ways you feel this committee could make any recommendations to assist you in discharging your functions at the Ministry of Health.
Madam Chair, I thank you for that offer. I would want to think more about it with my team so that when we can add it to our already comprehensive list of documents that we have promised to submit. I would, off the top of my head though, think about, and it has come up clearly, some of the constraints that we have, particularly in HR. I am not sure about the reach of the committee or how the committee will be able to operate in terms of assisting. And I think it's a systemic problem that our HR systems are severely under strain, so that when we have to be getting staff, whether it is the establishment through the Service Commissions Department or contract staff and renewal of positions, the systems are very onerous. We recognize the need for transparency, but I think that the time has come for all the players in the public system to be, and not just whether it is a public admin about public sector reform, but all the players, which to my mind would include honorable members who sit at a different level of public service, but when things do come, that the links are made between what we've talked about here and what is before you. So whether that relates to finances, HR systems, whether it relates to legislation, as sometimes we have in the case of helping with our NCDs, and I just say things like tobacco control. I don't know that it's on any agenda, but certainly a lot of what we would have discussed, and particularly for the dialysis, those would have come out of a real crisis that our country faces, and I don't think the ordinary person in the street recognizes how significant a problem it is, and at the end of the day it is a developmental problem. We have to use the limited resources we have to take care of people, and those people who are being taken care of cannot contribute in a productive manner. So that I think generally support for some of the programs that the ministry will be putting on the table at whatever level and in whatever way, that will be more than welcome, and it is a whole country approach. Thank you.
Okay.
If I
Dr. Missil.
The committee for this opportunity, and just to continue what our PS was disclosing, the Ministry of Health is particularly interested in what we call the health in all policies research and approach. And it is very important as the highest lawmaking body in the land for the support, especially Ministry of Health policy initiatives, and PS mentioned the whole NCD burden, because we went through a lot of details about dialysis and cancer treatments and so on. But I think it is very important that your level, that you indirectly and indirectly play your part and partnering with the Ministry of Health in confronting some of these disease burdens that we have to pay a lot of money to care for these people. Not that we deny them care, but sometimes the involvement of icons like yourselves in terms of prevention, in terms of your lifestyle, in terms of what you say and do, that you as role models for the society, it is very important that you all make an effort and a conscious effort to do that, so that at the end of the day, collectively, our vital statistics will improve as a country. Thank you.
Yeah, well, Dr. Buddha just reminds me we have a Gemini Parliament. Maybe I shouldn't make that an announcement. Anyway, I really want to thank the officials of the Ministry of Health, PS, Mr. Jai Singh, Dr. Misir, Mr. Koilas, Mr. Smith, Mr. Sitaram, Ms. Kaulasa, and Mrs. Pedro for this very interesting and enlightening conversation. I also want to commend you all for going beyond the duty. You know, some of us only know public servants who we say work truncated hours. Your willingness to be here at this time certainly puts light to that. We want to thank you. P.S. I realize this week is a short week and that Monday is a public holiday. So certainly if we could get the submission Wednesday, because I realize we've asked for a lot of things, we would be grateful. I want to thank the members of the media who stayed here with us. I want to thank the citizens who tuned in, both on our television channel and on the radio, for being part of this discussion, all in the interests of Trinidad and Tobago. This meeting is now suspended. I thank you. I wish you all a safe journey home.
Thank you very much, Chair and members.